All right, we're recording. I think. No, somebody else just joined us. If you want to call on the people who are not.
Call, no, I can't. But let's just.
Okay.
That's not working out, but don't worry about it. See, don't worry about it. I'll just push the button.
All right. Why don't you introduce yourself? Many of you who have taken critical care for at the very least remember Elbert. I think he was most of everybody. You don't know these two probably. I know you've talked to Steve today. Caroline, you've probably never met. You've seen her at a registry test that didn't get to finish.
Yeah, the one that I cheated, I was going to play in the
I was not there that time. I know about all that.
Well, she was sleeping in her head. You know, she wasn't cheating.
She was
when the woman called me from the state, she was like, "Did you sleep?"
not the state, National Registry.
Did you sleep over? I'm like, no, I was asleep. Did you sleep? No, I was asleep. She's like, well, at lunchtime, yeah, I didn't eat lunch with everybody else. They woke me up afterwards and told me to go get food. So I ate on myself.
So she,
well,
Lauren called me and she said, "How did you have somebody asleep?" I said, "Every time it was her turn to go, they'd wake her up. She'd go to her station, she'd come back and get in her hammock and go back to sleep." Yeah.
It's hard to get in trouble when you're asleep.
This is true. So let me introduce Elbert for those that are in Zoom land. Elbert Braswell is a practicing PA in Eastern North Carolina. He is also a steel card carrying paramedic, and Elbert had a devastating on the job injury. He looks devastated, doesn't he? He got bit by an electrical snake and had some neurological deficits that allowed him to have a disability claim that sent him to PA school, helped send him to PA school. I'm sure there was some out-of-pocket stuff. So he went to St. Louis and lived for 2 years going to PA school. 3, I'm sorry. Okay. Time flies when you're having fun.
Oh, I had a lot of fun.
So yeah, no, you're being recorded. Your wife may use this in divorce court. So anyway, Elbert participated in this class 2 years ago, 4 years ago, 2 years ago. So, yeah. Well, I mean, but you took the whole class 2 years ago, and then has been teaching for the class ever since. So his day today is pharmacology, and we are recording this. Folks in Zoom land, if you have questions, just type them into the chat, and I will ask them for you, or you can unmute your mic and say, "Elbert, I have a question." We have, we'll hear him through here. 2, 4, 7 folks present in the room and another 5 or 6 on Zoom land, Elbert, so carry on. Sorry, we're getting started an hour late. It's break time. No.
So, we're an hour late, so we'll get out an hour early. My name is Ben. I'm here for pharmacology. As you see here, each here, that's critical care transport.
Yeah, this is Daniel. I can't tell if somebody there is supposed to be talking, but it sounds like someone took the speaker to the bathroom.
Were you in the bathroom?
Me?
Yeah.
Yeah.
Okay, well, we can hear you going.
Oh,
Can you hear the presentation?
Can you hear the presentation? No.
The presentation, I think is supposed to be audio on the iPad. Is the,
Daniel said you don't hear.
Technically,
recorded.
Yeah, it's recorded.
nobody knows it was me.
They do now.
Yeah.
Yes, I was just looking to see if it's
So
not
it's
muted.
Glenn, they can hear you whenever you were introducing him.
Yeah.
But then after that, they can hear like a second and then they can hear you missing. So it's whatever you
Oh.
got.
My Bluetooth's connected to my iPad.
Okay, we'll fix it.
I love technology.
we know.
Continue. I'll buy you a new one.
All right.
No.
Ashley, can you still can you hear me now?
Yeah, I can hear you really well. I can't really hear anybody else though.
Okay, well, we're doing the sound off of my iPad, which is sitting beside Elbert's computer. So that should work. Somebody just joined or left. Okay, all right. Ashley, thanks for that. We're going to, are we still recording?
Okay, looks to me like recording and they can hear audio.
Okay, getting back to this slide here, going over factors related to medication selection during transport. The availability of optimal medication. Sometimes there has been drug shortages that they might need to be aware of, and they might change your medication to a different class. Transport team scope of practice and monitoring capabilities. I mean, if you're doing any type of critical care transport, you need to be able to monitor the patient, hemodynamic monitoring, airway monitoring, anything like that. So you should have your monitoring capability, and then the clinical status of the patient. Postpone any drug administration if immediate life-saving measures or interventions are required. Some other factors specific to each medication or the indication, the pharmacodynamics, the pharmacokinetics, the side effects of each medication, and the potential side effects. Everybody knows what pharmacodynamics and pharmacokinetics mean. They're both derived from Greek word. Form means drug, and codynamics means power. So pharmacodynamics means pretty much drug power, and then pharmacokinetics will be drug and movement of the drug in the body. Drug movement. How the drug is absorbed through the body and hits the target effect. Continuous factors related to pharmacokinetics. The absorption occurs immediately or shortly after the drug is administered, whether it's PO, sub-Q, IM, or IV, or EC2, endotracheal. And of course, the route of administration affects how quickly the dose is absorbed and how much the dose is absorbed, and the bioavailability. It's a tricky word. And of course, bioavailability refers to the percentage of drug that is active and available in the circulation after the initial administration. Some of them were a little tricky. I'm a simple person. So we continue with factors related to pharmacokinetics. The distribution, it can be highly variable, depending on the body mass or each individual, the sex of the individual, the age of the individual. Blood is the primary distribution vehicle, and of course, medication can be restricted by the placental and brain barriers, and also with first pass effect with oral medications to the liver. Biotransformation, liver is the primary site, and it involves 4 possible events. If you see in the picture there, if you take a pill with oral administration, you swallow the pill, goes into your stomach, you digest it, the medication is absorbed in the intestines and transported out of the intestine into the portal vein, where it goes to the liver, where it's metabolized to this active drug, and of course, then it goes into the bloodstream to the heart. And it's also, you see on the top part of the slide there, is the intravenous injection. Of course, you do IV drugs, you pretty much skip all the other part of it, just go right to the bloodstream. Any questions? Like I said, this is pretty much all refresher. You should all be pretty much aware of all of it. The thing factors related to pharmacokinetics is excretion. It's a process by which the substance, by the drug substance, are eliminated from the body by 2 systems. The kidney, the renal system, is a predominant site for excretion, and then the hepatic system is excreted from the body through the bile and the feces. And look at those 2 processes of excretion. some things we need to take into consideration, especially if you have someone who's in liver failure or someone who's in kidney failure or anything like that. It might take longer for that drug to be excreted, and then you could actually be given medication. It could be added up to a summation or added to the effect. I had a 28-year-old male this past week. He came in for nausea and vomiting. No medical history whatsoever. 28 years old. He was complete renal failure. So it happens to young people. Never had a history, no family history, and he had a creatinine of over 21. So he went on dialysis. But it happens to everybody. So. And then it's kind of funny because it happened the same rotation last week. The first day I had a 28-year-old in complete renal failure, and the second day working, I had a 48-year-old, 53, who was 53-year-old, who was in complete liver failure due to hepatitis A that he contracted doing sewage work with no gloves on. And that's how he. So make sure you wear gloves when you're doing sewage work. But he had eczema on his hands. He had a way for the bacteria to be absorbed through the skin. He was diagnosed with hepatitis A about a week before, and they had not watched his liver function. And he came into the ED complaining of a headache. And of course, when I saw him, he kind of looked jaundiced. He had no history of liver problems other than just being recently diagnosed with hepatitis A. And now he's in complete liver failure. We had to send him to do. So no matter how old you are, young people, older people, that's some of the things you might need to be aware of, because the guy in renal failure, there's no need to give him a lot of medication because it's going to be excreted through the urine. It's not going to be excreted unless he will be dialyzed anyway, so it'll get out that way. Theories of drug action, medication. They may bind with some receptor sites to promote or inhibit a specific cell activity. They affect the cell's physical property to alter its functioning. Combine directly with other body chemicals to alter or limit chemical effects or allow it to be removed. And they also alter metabolic pathways to achieve desired results. Effect of the molecule on the receptor site. Those that stimulate the receptor site to cause this normal response is called an agonist. And those that block the receptor site from being stimulated are called antagonists. These are terms we have always been familiar with. More drug response relationship. The classical level profile describes the length of onset, the duration, and the termination of action. Onset of action is the time it takes for a medication to reach its target tissue, to reach the minimal effective value level. And the duration of action is the amount of time the medication remains above the minimal level to give it a therapeutic response. Termination of action, the time between the concentration falling below the minimal to elimination from the body. And the therapeutic index is the medication's margin of safety. And the half-life time is the time it takes for the body to eliminate half of the medication, either through the renal system or the liver. Pharmacodynamics refers to the study of the effect of a drug on the body. The healthcare provider should be aware of the factors that can alter medication action. I think we brushed up on that a few seconds ago. Factors affecting drug response is the age. Pediatric and older patients process medications differently. The patient's weight, medication calculated on either ideal or actual body weight. And we have a nice little formula on the computer so we can calculate that for us. And by sex, the body mass differences may affect reaction. Also, the environment can create a psychological or physiological stress. Time of administration in relation to eating, especially doing PO medication. The overall health condition of the patient, like we mentioned, those with liver failure, or even elderly people who might have some renal insufficiency, probably history of heart failure and other medical conditions. Be aware of that. Patients in shock, and also hypothermia. Genetic factors also affect drug response because of lack of necessary enzymes, can also slower metabolism. And then maybe be concerned with women who might be pregnant or who are pregnant. And some medications may harm the fetus or the mother. So you need to be aware of your drugs that you have in your truck and what the pregnancy class are of each one. And the psychological factors, the placebo effect, analgesics, and sedation. And of course, the FDA does have a category for medications, which is all listed on all the drug inserts, any type of medication information that you have. Category A is a medication that is safe to be used in pregnant women, and it has failed to demonstrate any type of risk or harm to the fetus in the first trimester. Then you got your category B is relatively safe too. Either animal reproduction studies have not demonstrated a fetus risk, but there are no control studies in pregnant women. And it's hard to find pregnant women who would like to be in a drug study for medication study. Yeah. And then for class C, category C, either studying the animal. Either studies the animal have a real adverse effect on the fetus. There are no control studies of women. Drugs should only be given if the potential benefit justifies the potential risk to the fetus. And then, of course, when you get down to D and X, there definitely should not be given to pregnant women, and there are serious evidence of fetal risk. And in category X, they have demonstrated fetal abnormalities. So you need to stay away from C, D, and X if possible, but C you can use if the potential benefit justifies the potential risk to the fetus. So A and B's are safe. Type of responses, you got the predictable, if we anticipate unexpected response side effects, consider risk benefit ratio, and determine if the patient is in a high risk group. And then you have the heterogenic response, drugs lead to symptoms that mimic naturally occurring disease states. The only thing I can think of about the heterogenic response is pretty much if someone who has cancer doing radiation therapy or chemotherapy, and of course you need to do chemotherapy and such necessary and be aggressive to have the therapeutic effect, but then the effect of the chemotherapy and the radiation therapy can give you like hair loss, anemia, diabetes, nausea, vomiting, infertility, and that would be an iatrogenic effect from the medication. How to respond, unpredictable. Every medication has a possibility to have an allergic reaction. Idiosyncratic reaction, cross tolerance phenomenon. That's kind of unusual. Cross tolerance phenomenon is like when you give a patient a medication, you can get it for years of a particular Benzo or something. And they take it every day, every day. And then next day, they are, doesn't have the therapeutic value that has been given, but nothing in that same class has any therapeutic value. So they give the medication the whole time, and then that medication quits working, and then you go to another medication in the same class, but that medication has no effect. And it's because they have a fault tolerance from the first medication. Because we've heard a lot about drug dependence, cumulative effect, drug interactions. Every drug has a lot of times interacts with other medications. If you're not familiar with the drug interactions between the two, I use an app for possibly insert as many drugs you want to, hit enter, and it tells you all the reactions between the two. It's hard to remember all that. When you have an app, it's so much easier. Tips for avoiding medication errors, and this has been beaten up ever since I've been remembering paramedic school. Ensure the right patient, the right drug, the right dose, the right rights, the right route, the right time, and the right formulation of medication. That's a biggie. Evaluate medication decisions made by the facility staff for errors. Anytime you do a transfer, when you come to the emergency department, you should look at all the order forms. Just double check it. Everything. If you have questions about any of those orders, you need to ask the charge nurse or the sending physician for corrections or what needs to be addressed. And then also confirm accuracy of medication infusion. Occurring in transport, same thing. Look at your transport sheet, see what medication is being infused and what the infusion time is. And then, of course, make sure everything's properly labeled and make sure all medications are you don't have anything incompatible when you're pushing medication to an IV site. And storage, I know when I was a paramedic in eastern part of the state, we always had trouble, especially heat and everything. So we had to end up getting new refrigerators, put in the truck to help with storage, keeping from being overly heated. So make sure you have a storage is correct, avoid temperature extremes, avoid exposure to direct sunlight and humidity, properly equipped with transport vehicle. And there's some medication that is light sensitive, so you need to be aware of that. And security, you follow your state federal guidelines for controlled substance storage and administration. We see a lot of problems on our side. I'm sure y'all have the same thing, but we have a lot of potential patients who abuse the system, and they actually have maybe like a substance agreement with their local primary care physician to get narcotics on a regular basis for pain management. And we have them call EMS for back pain and everything. Of course, EMS gets there, and oh, you're hurting. They get slammed with morphine or fentanyl or something, and they get their fix. And then they bring them to the ED, and they're like, "You're not getting nothing for much." In the back. So every time we have a patient that comes in, especially with narcotics, we have to go to the narcotic drug site website, put their name, date of birth, and see if they have any abuse pattern noted throughout the state. And luckily now, I'm so close to the Virginia line, I can input Virginia and get Virginia. I can pretty much click a lot of stations around an area and get if they got any medication fields in Virginia, wherever. I had a lady about 2 months ago came from Florida to where I work at, doing some work on some houses and everything. And I noticed that she came in a couple of times in the last couple of months for pain. So I ended up talking more about it, found out she was coming from Florida, coming up and doing some work on some houses. So I ended up putting Florida in the database, and she had a whole thing. She would go from Florida, Georgia, South Carolina, and get narcotics as well. So the website is a great resource for us. They don't have that option, but we do have the option, and that does help us to decide whether we need to write prescriptions for them and stuff like that. So make sure you follow your state, your federal guidelines for controlled substance storage and administration. And follow your local protocol. Medication specific to critical care transport. Drugs are usually organized on the classification rather than their uses. So, same medication, but they'll have multiple indications. Dosage, kinetics, related materials vary from one source to the other. And like I said earlier, to make sure you follow your local system or for your protocols regarding administrative guidelines for each medication. I need to stop here and switch to another slide. Figure out how to do this.
You give them a break.
Yeah, give a break so I can switch this 5-minute break. So I just X out of this? Any more big? Down. Down. No one wants a break? We're going. I don't know. Okay. I'll give you 5-minute break. Give me a chance to swallow my food. I'm off to a small. Oh, this side. Maybe this side. No. I'm on time for the one. Daddy, walk on that one. Or no, that one? How about that one? Detroit. That is the little, you know, she was really much really that's the thing you do, like. They have a place on me. Actually, one of them. No, it's one thing that we just not yes. It's not the most I have 14 and put the name on the sheet.
I said, did you buy me I said, if you want us to place beyond the time, the service. I've never heard of it. You watch it, you come there. This is the
You can help my
it's just like a game.
game,
Gamer.
game, yeah.
Yeah. I mean, all of the aspects of it, whenever I would like to do, I would say no. And I would say, you know,
Can't do that.
but now my middle brother is the best.
You're gonna be insecure on most. Well,
Well-
you gotta remember the baby had nothing to do with it.
But, yeah.
You got to support the baby.
I asked her, I said, they were like, well, I didn't got this in the middle, that we can, prenatal. We call it prenatal. And I don't know,
Less than two.
I don't know how the, like, pregnancy medication works. But like I told my brother, y'all look at the ball, you go up there and fill out some paperwork. And,
Let's start back real quick. Going over pulmonary pharmacology. Airway obstruction. The airway caliper and tone are regulated by the autonomic nervous system, either by the sympathetic or the parasympathetic system. Sympathetic system has the alpha and beta receptors, and the highest number of beta receptors found. And then the parasympathetic cholinergic receptor with the highest number being found in the trachea and the large bronchi. Parasympathetic stimulation, acetylcholine stimulates the cholinergic receptors, increases the level of cyclic guanine monophosphate. That's it. Cyclic guanine monophosphate. Stimulation increases bronchial constriction, mast cell degranulation, and increases granular secretion. The CGMP kind of helps relaxes the smooth muscles of the lungs and tissue. And we have your sympathetic stimulation. Beta 1 and alpha receptors have little effect. And then you have your beta 2 receptor stimulation. Always remember beta 1, beta 2, 1 heart, 2 lungs. Beta 2 receptor stimulation increases level of cyclic adenosine monophosphate and causes bronchodilation. And the receptors are stimulated by endogenous catecholamines and drugs. Anticholinergic stimulation blocks choline from stimulation of the cholinergic receptors, stops the production of CGMP, and the result of bronchial constriction. And the allergic stimulation also prevents bronchial constriction. It's not very useful in treating existing bronchial constriction. Classification of bronchodilators. You got respiratory smooth muscle relaxers, the theophylline and aminotheophylline. And of course, the one we're more familiar with is the beta 2 agonist, albuterol, butylene, isoproterenol, metaproterenol. And then the anticholinergic agents are the atropine, epitropium. Theophylline mechanism of action is unknown and may cause a decrease in CAMP degradation Federation. And it may antagonize the adenosine receptor, and it may inhibit prostaglandin. So they don't know much, but it does work. Pharmacological action is great bronchial muscle relaxant. If bronchoconstrictor is not present, it has no effect. Has a positive inotropic and positive chronotropic properties. And increases diaphragmatic contractility. It also has some properties of vasodilation, diuresis, CNS respiratory stimulant, and it stimulates gastric acid institution. Some of the side effects is most common is nausea, vomiting, and anorexia. And then you can also have some headache, irritability, nervousness, dizziness, and seizures. And it's noted here that those that have having seizures with use of theophylline, they have a 6% increase in mortality. So cardiovascular side effects include palpitations, spinal tachycardia, multiple focal atrial tachycardia, flushing, hypertension, ventricular arrhythmia. In the dosage form, there's over 150 different products better than the United States. You can either give it oral or intravenous. Right, there's not recommended. There's a place for theophylline therapy. It has to prevent prevention of bronchospasm. And it should not be used in the initial treatment of bronchospasm. Use a beta agonist first. And then if they fail, then you may try IV theophylline. Not many drugs will have that on EMF, but you might be transferring the patient. You might be having an IV infusion. Low doses, if the patient has not had theophylline in the last 24 hours, it's 5 minutes per kg, and you administer at low dose every 30 minutes. And if the patient has theophylline, it's 2.5 minutes per kg. Follow your local protocol for the physician orders. And these are some of the maintenance doses. You can see them now and go over there. And theophylline has an increased clearance with those who smoke, those who are on phenobarbital, phentoin designed for seizure prophylaxis, Tegretol for after procedures, rifampin, and a truffle diet. So like we were talking about earlier, there is a lot of medications interactions between the things. So with theophylline, so the medication increases clearance of the medication or drugs goes with It's just to be aware of your side effect and your drug interaction. And things that decrease clearance, of course, liver failure, heart failure, poor pulmonale, erythromycin, which is an antibiotic. Clement antagonist is a H2 blocker. Zantac. And from theophylline, we're going to the beta agonist, used for both acute and chronic airway obstruction. It increases the level of cyclic adenosine monophosphate, which is an inhibitory effect on bronchial muscle. Prevents mast cell degranulation and prevention of histamine. And it varies from drug to drug to the degree of beta 1 and beta 2 action. Epinephrine and isotretinoin have equal beta 1 and beta 2 action. And albuterol, metoprolol, and cebuteline have predominantly beta 2 epinephrine and isotretinoin are ineffective given orally. And metoprolol, albuterol, cebuteline are all effective orally. And of course, inhalation is the preferred method of administration. How's y'all administration of albuterol since the COVID virus? Have y'all had a lot of cases here with COVID? Because COVID is a respiratory droplet. So anytime you airlize medication, albuterol, if you're not having an increased droplets in the air.
We grade those models and stuff and all that.
Now, how about airway management? Do y'all intubate or do y'all have to, we have to have a plastic box. We have a plastic box.
We don't have a box here, but anesthesia companies.
We have a plastic box. And it's hard to intubate something into there. I got upset here a couple weeks ago. I just moved the box up and intubate. But we've seen quite a few down that, we're not as many deaths as like Mecklenburg. My wife was diagnosed with COVID. She was in ICU for a couple of days. But her situation wasn't COVID related. It was just one of the things. Oh, she had COVID too. But I think she got it from the hospital itself. Hospital acquired COVID, especially. But yeah, we're doing a lot of preventive things in the hospital, especially if the patient, if we think they have COVID, then we can't give any type of airline medication, then we'll just have to use an inhaler. Some of the advantages of inhalation therapy: the drug is delivered directly to the site of action, the airway. Smaller doses of the drug is needed to achieve a therapeutic response, and the onset of action is relatively rapid with minimal side effects in given 5 minutes. The disadvantages: the patient cooperation is definitely needed. Difficulty time pressing the inhalation, the inhaler, and the inspiration. And of course, patients are recommended. And it may be difficult to reach the airways in patients with severe bronchitis. Beta agonist drugs, epinephrine to be administered inhalation or by injection. Isoproterenol, same thing. And metaproterenol, inhalation of PA, and those are the direct duration of action. So you've got terbutaline, can be given injection, inhalation, or PA. And albuterol, inhalation and PA will be EMS, with transport, mainly preferring inhalation therapy. With duration of action of 4 to 6 hours with albuterol. Side effects of a beta agonist, with inhalation is very rare to have a reaction. But if you give it injection or oral, tachycardia, because we always get patients with albuterol, they always get a little bit jittery and stuff like that. But usually rare, but with injection or oral, you have more increased tachycardia, hypertension, tremors, and nervousness. IV epinephrine and isoproterenol. And one of the bad side effects is it increases the myocardial oxygen demand. So if you have a patient who, especially with those with COPD or any type of respiratory lung problem, they probably have an underlying heart issue. So now you're stressing the heart with an increased myocardial demand. And then, of course, limit the use of patients with limit the drug unresponsive bronchial stress. There's always side effects to every medication. Beta agonists are the first-line therapy for acute bronchospasm. It could be prophylaxis in chronic asthma and prophylaxis in exercise-induced asthma. All beta agonists are pretty much equally effective. It's pretty much a matter of physician and patient. Anticholinergic agents have been used since the early 1800s with a high incidence of side effects, urinary retention, tachycardia, and delirium. There are, of course, less toxic forms available now, with atropine and ipratropium. Some of the anticholinergic agents' pharmacological effect is key with acetylcholine receptors, inhibit the production of guanine monophosphate, and they cause bronchodilations, and they increase in secretion. Some of the side effects: dry mouth, lightheadedness, tachycardia is rare with inhalation therapy. May increase the viscosity of the secretion. Side effects: you have more side effects with atropine than you do with ipratropium. Clinical use: the alternative to beta agonists. It is less effective than asthma and has a slow onset of action. And because we don't use it in acute bronchospasm. Can be used in conjunction with a beta agonist, and patients do not adequately respond to a beta agonist alone. So you know, always add it in with your albuterol. Doing it. Corticosteroids They decrease inflammation of the airways, may increase the density of the beta 2 receptors, and they're available either injection, oral tablet, and solution, and inhalation. With inhalation, there's a slow onset of action and is not recommended for treatment of acute attack. IV has rapid onset. Used when beta agonists alone have not been successful. Intravenous use of acute bronchoconstriction. Even after a beta agonist has been used, anywhere the dose is anywhere between 80 to 125 milligrams of Phenylmedrol every 6 to 8 hours. And when the bronchoconstriction or the attack is controlled, you can switch to a comparable oral dose. It does. Well, it has a lot more effect. I think the duration of that.
It's about 45
Yeah,
minutes. We all said it. Sorry.
Yeah.
But the sooner you get it, the sooner the 45
Yeah,
minutes.
but I mean, that's not the full saying that the IVs immediately.
Well, it gets into the actual, let's see, I'll tell you the exact apocryphy. Sorry, my apocryphy is not working.
It's fine, I just didn't know if there was something I didn't. Because the solid before you said that starts immediately. Obviously.
It's a very, it does say rapid onset used when beta agonists. Anytime you get, I'll give you the definite time frame since you get internet or something for my phone. But definitely we do beta agonists first. That has rapid onset because inhalation, the drug affects right to the airway. IV use definitely has to go to the bloodstream to the target effect, but it should start working within an hour. And I'll give you a definite time frame. But we do that by the time you get the steroid on board, and hopefully you'll be able to break the attack with repeated doses of butyrol, and it should all be kicking in. But I'll give you the exact times here in a little bit. I thought you said ooh.
Well, like, you started with something.
Oh, I got you. Corticosteroids, inhalation is used in conjunction with the beta agonist for chronic control, and they have a role in patients who find a beta agonist more than 3 times a day. There's a lot of different brand names out there for beta agonists, like Urol, Preventive, Vitamin, Butylene, Brethine, Ibuprofen. Brand names for Theophylline. I haven't seen Theophylline used in a long time. I don't use it that much. And I close it. After that. Okay, brand name for Dexamethasone, Dexamethasone, Dexamethasone. We just switch to another set of slides. Antihypertensive medication. Hypertensive crisis, causes of chronic hypertension, renal disease, preeclampsia, head injury, or hemochronic sarcoma. Everybody know what hemochronic sarcoma is? It's a rare adrenal gland tumor in the adrenal gland. Usually, sort of gives effects like nothing else, like increase heart rate, metabolism, and things like that. A rare adrenal gland tumor. Causes of hypertensive crisis, medication, cocaine, amphetamines, diet pills, monooxidase inhibitors, thiamine-containing foods, symptomatic agents, and then we have a rebound from antihypertensive therapy. Thiamine foods are like smoked meats, aged cheese, some beans, fava beans, beer. I don't drink beer. Grapefruit. Autoregulation is the ability to maintain suitable blood flow for a range of blood pressure through vasodilation and vasoconstriction. And chronic hypertension raises both the upper and lower limit of autoregulation, and trauma increases the lower limit. Hypertension urgency, defined as an elevated blood pressure associated with a risk for imminent target organ dysfunction, and with a diastolic blood pressure greater than 120 millimeters of mercury. Goals of therapy is to decrease the blood pressure over the next 24 to 48 hours with an outpatient follow-up. We do that quite a bit in the emergency department. We'll bring it down slowly and make sure they have the follow-up appointment with their primary care doctor. Treatment options are clonidine, amphetamine, hydrolazine, Betalol, methanol. With the urgency, you probably won't see that in a transport situation, but a lot of times we can control that in emergency department and we discharge them as an outpatient. But with the hypertensive emergency, you might see that needing to be transferred to a tertiary care facility. Definition for hypertensive emergency: diastolic blood pressure greater than 120 millimeters of mercury associated with in-organ dysfunction. And the goal of the therapy is to decrease the diastolic blood pressure to 100 millimeters or by 25% within the first 1 to 2 hours. And avoid rapid reduction, and you want to be able to minimize the blood pressure over 1 to 2 weeks. In-organ damage includes hypertensive encephalopathy, failure other regulation, severe headache, nausea, vomiting, visual changes, confusion, or focal generalized weakness. Then we're going with CNS, seizures, hyperedema, AV leaking or hemorrhaging, sedation, and because we have a rollout of clinical pathology with a CT scan. And in order to damage the renal, we call it acute renal failure, hematuria, and proteinuria. And that's what was wrong with our gentleman who was 28 years old. Ended up, he had a long-standing history of high blood pressure, but he never had it treated. So now he's getting treated and downsized it. So. ACE inhibitors, they're used to decrease both the pre-mode and after-mode. Most don't work very fast. The session would be the IV, caterpillar IV NFL. Recommended for hypertension, heart failure, and post-cardiac infarction. And the adverse effects is hypertension, hyperkalemia, angioedema, and cough. The thing about angioedema, it can happen after the first time you take your ACE inhibitor. It might be 2 or 3 years you've been taking it fine, and the next time you take it, you have an angioedema. We actually had a person actually die a couple of years ago because severe angioedema, and we can't get it early.
The one I have, I'm saying, is the same. Airway.
They survived?
Yeah.
Yeah. Ours didn't. They even tried to do a trach in the ER.
They were amazing.
Caterpillar, pharmacokinetic, onset 15 minutes, duration 4 to 6 hours, observable response, potentially acceptable response, and of course, dosage is PA 6.25 milligrams per day. Not that y'all probably see this in the truck. Calcium and channel blockers, the 3 major classifications, phenolphthalein, Braswell, dihydroxyphosphine. Each class binds at a different state. Braswell and dihydroxyphosphine is when the calcium channel is open, and the phosphine is in the resting state. The effects of calcium channel blockers is vasodilation, with a decrease in systemic vascular resistance, decreases contraction of the myocardium and O2 consumption, and decreases heart rate and conduction. The adverse effects of calcium channel blockers is dizziness, constipation, hypertension, headache, peripheral edema. Clonidine, catapult, and inhibits the CNS and decreases sympathetic outflow. It reduces the heart rate, vascular tone, and reduces blood pressure. It stimulates the altitude adrenergic receptors. Has an onset of half an hour to an hour. The duration is 6 to 8 hours. 6 to 8 hours. And it is excreted through the renal and hepatic system. Dosage is either 0.4 to 0.4 milligrams per kilo. And for nothing value you need to start with, they just start out 0.1 milligrams twice a day and increase it by 0.1 milligrams every day to get a therapeutic response if you want blood pressure. With a max dose of 2.4 milligrams. Hydralazine, Braswell, I use this a lot. I like this drug. Greatly dilates the peripheral vascular, works on the renal, splenic, and coronary arteries, and it's excreted mainly through the renal system, and it has a half-life of 3 to 7 hours. Dosage, hypertension, moderate and severe, 10 to 50 milligrams PO 4 times a day. So 10 milligrams PO 4 times a day for 2 to 4 days, and you may increase it to 25 milligrams. And what I use it mainly in the emergency room, and what y'all will be using for hypertensive crisis, 10 to 20 milligrams. And then put a pocket there, 10 to 20 milligrams, IM or IV every 2 to 4 hours. Side effects of Braswell for hypertension, headache, tachycardia, angina, palpitations, and nausea, vomiting, and diarrhea. That's the most common side effect of most medication you see is nausea, vomiting, some type of GI effect. Sodium nitrophosphide, direct arterial and venous dilator. Onset within seconds with IV. Duration 3 to 5 minutes once you turn the IV off. And it's excreted through the renal primarily. Dosage for hypertensive crisis, 3 to 4 micrograms per kilogram per minute IV. You start at 0.3 to 0.5 micrograms per minute IV and then increase it for your response with a max dose of 10 micrograms per kilogram. And this is a medication that you need to protect it from the life. And usually we have a brown cover bag over it. Some of the adverse side effects for hypertension, dizziness, bradycardia, restlessness, delirium, headache, muscle twitching, reflex tachycardia, cyanide toxicity, labetalol, pharmacokinetic. This is selectively antagonizes alpha-1 adrenergic receptor and antagonizes beta-1 and beta-2 adrenergic receptor. Onset 5 to 10 minutes for the duration of 3 to 6 hours, and is excreted through the renal and hepatic system. Dosage for hypertensive emergency is 40 to 80 milligrams IV every 10 minutes as needed. Start with 20 milligrams IV, and you do an alternative dosing of 2 milligrams per minute for the IV infusion. And of course, for just hypertension, we usually do a PO dosage. So y'all will be most likely to be transferring some of the beta-log to it. Side effects: hypertension, dizziness, bradycardia, congestive heart failure, bronchospasm, nausea, vomiting, headache, and angina. Preeclampsia. Definition is a blood pressure greater than 140/90 after the 20th week of gestation with edema, proteinuria, and seizure. For drug choice for preeclampsia will be labetalol, 20 milligrams IV with repeated boluses, 40 to 80 milligrams to max of 300 milligrams. Or hydrolysine would be the second choice, 2.5 milligrams IV initially, followed by the 5.2 milligrams IV every 10 minutes. And that's for the blood pressure control. Of course, if the patient has seizures, actually we need to give the magnesium 1 to 2 grams IV bolus. But bring the blood pressure down. Keep the hypertensive, and the labetalol is good for pregnant women. Any questions? This to be an antagonist and proton pump inhibitor. This is a short slide, and after this, we'll take a lunch break. This to be an antagonist and proton pump inhibitor. Stress ulcer prophylaxis is undertaken in critical ill patients with associated risk factors for more than 48 hours, such as coagulopathy, severe sepsis, or mechanical ventilation. This the antagonist and proton pump inhibitors reduces the effect of gastric acid on the stomach walls and intestines to prevent the development of ulcers. Stress ulcer prophylaxis should be discontinued once these factors are resolved. Histamine 2 blocker medications include Pepsid, Antagonist, and Zantac. The reason why Zantac is highlighted in red, they just took that off the market April 1st of this year due to a lot of contamination of the medication, and there's a lot of lawsuits for cancer. How when's last time you got it? Unless it has a new formulation of it, as a April 1st. April 1st.
They made us pay more. It's hardly a, we put some, I don't know. It's just from the
Different manufacturer.
manufacturer, yeah.
What's
It's really hell.
and quarantine Hippocrates was withdrawn from the U.S. market April 1st, 2020 due to contamination with a probable carcinogenic. Switch to alternative methods. Well, they
No,
come
they
up with-
took whatever it was. It's really hell.
But I mean, you know,
They took that on and replaced it all against it.
I mean, you know, they might replace it with that or something like that.
They said that.
Is it that?
No. No, that's why I was like,
Must be.
Who's working there? You work tonight.
With Zantac.
yeah, it's still on the truck. It's
So, you know, you still might have it when your stock supply.
yeah.
So,
Oh, no, we took these off, but they brought us different ones to take off the ones that were manufactured by L.
Okay.
And then we had to replace those.
I'm going by what?
Oh, yeah, it's whatever they did. I don't know.
Take pictures.
I mean, unless they did a different formulation and got that one that carcinogenic, put the trucks around. Give it to people you don't like. So.
I don't know, but it's still there, I tell you that.
You can probably still find it at Walmart. Well, not Walmart. You can probably find it at some dollar store or some kind of thing like that. And you probably find it.
I ain't gonna lie, I had to.
Yeah.
Oh my God.
You get cancer, you know where it's from.
Yeah, whatever.
You get you some money from that lawsuit. But histamine 2 blocker medications for Pepsid antagonist, and then your proton pump inhibitor, metoprolol, pantoprazole, methazole, omeprazole. Pepsi, selectively and headed on the histamine H2 receptor, causing it to decrease gastric secretions in the stomach to decrease acid production. Onset 1 hour PA, 30 minutes IV, and duration is 10 to 12 hours, and it's excreted through the urine primarily. Dosage is 20 milligrams IV every 12 hours, or 20 milligrams PA to the IV. Side effects: headache, dizziness, constipation, diarrhea, and taste changes. Nexium, another H2 blocker, inhibiting gastric cell hydrogen potassium ATPase. And this is a proton pump inhibitor. Take your PPI. Has a rapid onset and the peak effect is 1.6 hours. With a duration of 24 hours. And it's treated through the renal system. Dosage is 20 to 40 milligrams IV every 24 hours. And there's the alternate dosage, 20 to 40 milligrams PA every day. Side effects: headache, flatulence, diarrhea, nausea, abdominal pain, dizziness, and vertigo. Yeah. Right.
There's Stomia.
Dry mouth. Dry mouth. Dry mouth. Proton, this is what I usually use. I use this a lot in ED, works great. Another proton pump inhibitor, onset 15 to 30 minutes, with the IV with a half-life of 1 hour. And urine straight to the urine, 71%, and patients with the balance.
And you're tripping, it's all on your foot.
And it does proton, we have to go 40 milligrams IV every 24 hours with an alternating of 40 to 80. And you live there. TV. Side effects: headache, diarrhea, abdominal colitis, and nausea, vomiting, and flatulence, and liver function. Yeah. Any questions? You got time for another slide? You got to find a short one.
One short line.
I know. Everything else gets like a lot. That went faster than I thought it would do.
Thanks, Doug Buffett.
Let's go ahead and do the break for lunch because the next one's going to be a lot longer slide. That's the shortest one I had.
Dinner time, we should have everything.
That's the day when we put on. Well, we can all, wherever you look out. Okay, Dougie. Can't remember.
But the
I'll
old
text
one,
you.
but the old one.
We had to do the same thing before.
Okay.
No, that probably just really old. If you would rather have a different pattern.
But even had to sign that before. I think like, well.
We haven't gotten them. They got that, yeah, I'm not sure do.
But you can't remember what he put back on there, but I'll text Daniel, Daniel was in drug on.
Yeah, that's right. Daniel, you do it on you.
Oh, no, it's bad. But they replaced it with something else. With a different yeah, but we haven't changed the, because it was on, $4 on the.
Caroline, I'm gonna talk to the meat people.
All right.
So, one word. Be quiet. Huh?
I said something.
Quiet.
Ashley and Daniel and Dave Parker and Doug Sasser, we're going to lunch. We'll be going, oh, and Snowball. We're going to lunch. We'll be gone till about 1 o'clock. I'm gonna pause the recording and I will try to text everyone that we're back. Ashley, I don't think I have your phone number. And Snowball, I know I don't have yours. He is, but I don't have his phone number. Okay, Steve says he's got yours, Tyler. So Ashley,
Yes.
you have my number?
Yes, sir.
If you'll go ahead and text me, I'll text you when we get back. All right, guys, we'll see you in about an hour.
All right, thanks.
Well, I'll ride with somebody, because I ain't driving.
You can ride with me. Excuse me.
Where are we going?
And Susan's one of those things too. No, Wednesday no Mexican because he can't have adult beverages.
Oh, gosh.
That's not mine.
It's mine.
Turn it off.
Turn it off.
Turn recording.
Yes.
Yeah, I see what you now. Leslie, do you remember Elbert?
I would have to see a face with a name. I'm not sure. Should I remember Elbert?
I would rather see your first side, Elbert. Seen a newspaper.
I don't know if you might recognize the backside too.
God, what kind of girl do you think she is?
Ain't nothing wrong with one man's butt.
Good, girl.
I will continue on with vasopressor. Vasopressors, they induce vasoconstrictions, they elevate arterial blood pressure, and they exhibit some inotropic activity. They are indicated in distributed shock states, and they are significant in high tissue necrosis and ischemia related to vasopressor. Uses are the optimized hemodynamic parameters, cardiogenic shock, multi-system organ failure, hypothalamic shock, and septic shock. Alpha receptors, physiology and stimulation of the alpha 1 receptors causes a increase in vasoconstriction, increases the blood pressure, and decreases cardiac output. Dopamine, the precursor to norepinephrine, and stimulates norepinephrine release. Effects are dose dependent and titrated to the desired response. And you come to the value of 40 doses, 250 ml. Half-life is 2 minutes, and it varies excreted through the urine. Low dose is pretty much referred to as the renal dosing, 1 to 3 micrograms per kilogram per minute, and it stimulates a dopaminergic receptor, which dilates the renal artery, increases urinary output, causes some increase in cardiac output, and some unaffected activity. Moderate doses, 5 to 10 micrograms per kilogram, predominantly affects beta-1 receptors more than beta-2 receptors, increases cardiac output, increases the heart rate, slight increase in blood pressure and pulmonary capillary wedge pressure, with a slight decrease in systemic vascular resistance. And with the high dosing, 10 to 20 micrograms per kilogram, may alpha stimulation can affect the beta effects, results in vasoconstriction, increases the blood pressure, the systemic vascular resistance, increases the heart rate, pulmonary capillary wedge pressure, and it decreases the cardiac output. Some of the common reaction to adverse effects of dopamine. Common reactions include headache, nausea, vomiting, tachycardia, vasoconstriction, angina, cardiac conduction disturbances. And of course, the adverse effects is the stagnation of the first anaphylaxis, bronchospasm, tachyarrhythmias, and hypertension. Epinephrine, endogenous catecholamine that stimulates the alpha and beta receptors with a half-life of less than 5 minutes, and its excretion is due mainly to the renal system. Low dose, 0.01 to 0.05 grams per minute. With the beta-1 receptor is affected more than beta-2, causes an increase in cardiac output and heart rate, and decreases systemic vascular resistance. High dose, greater than 0.05 micrograms per kilogram. Alpha effects, in addition to the beta effect, increases heart rate, blood pressure, cardiac output, and decreases urine output. And of course, epinephrine administration is 1 to 2 milligrams in a 250 to 500 ml bag with a continued infusion, hopefully through a central line, and of course, titrate the desired response. Side effects: palpitations, tachycardia, nausea, vomiting, tremors, and headache, with the adverse effects, which include renal impairment, hemorrhage, skin and tissue necrosis, pulmonary edema, norepinephrine, Elbert, pharmacology, alpha effects, some beta-1 activity, increases blood pressure, systemic vascular resistance, and pulmonary capillary wedge pressure, decreases urine output, and has a slight decrease in heart rate and cardiac output. Half-life is 1 minute, And it's screened through the urine. Dosage is 2 to 20 micrograms per minute, which is titrated to respond, and usually administered via central. Side effects, of course, the headache, bradycardia, dyspnea, anxiety. Of course, the adverse effects, hypertension, asthma, exacerbation, arrhythmias, ischemic injury. Butamine, used for inotropic support, improves oxygen delivery to tissues, mostly beta effects, alpha and beta 2 activity at the higher doses. It has a half-life of 2 minutes and is excreted through the urine. Y'all carry dopamine on truck, butamine and stuff? Dosage for butamine is 2 to 20 micrograms per kilogram, for the titrated to the spot. It may be infused by peripheral IV. So imagine dosage. And butamine is a drug of choice in cardiogenic shock. Increases cardiac output and urine output. Decreases systemic vascular resistance and pulmonary capillary rate pressure, with minimal effects on blood pressure and heart rate. Butamine side effects for the hypertension, tachycardia, PVC, providers, nausea, and headache, and for the adverse effects include ventricular tachycardia, hyperkalemia, thrombocytopenia, bronchospasm, hypertension. Here's a table chart for different classes of medication, such as butamine, dopamine, further inotropic class, dosage. The other one y'all carry is glutamine. But as a critical care transport, you might be transporting someone on the butamine, levothal, so they're not resistant to. Usually it's never good when you put them on levothal. Yeah. You can almost bring a pulse back to a rock. Thrombolytics and anticoagulants. Critical care transport paramedics will encounter situations that require dissolution of blood clots with thrombolytics and of course prevention of blood clots with anticoagulants. Goals for thrombolytic therapy, which is a life-saving hormone, limiting the infarct size, that is infusion, decrease morbidity, preserve less ventricular function, and decrease mortality. Thrombolytic therapy, absolute contraindications, major surgery within 6 weeks, a GI within the last 6 months, intracranial neoplasm, a stroke within the last 6 months, any active bleeding other than menstrual period, and then head trauma within 1 month, and pregnancy. Relative contraindications, CPR greater than 10 minutes, age, hypertension greater than 180 over 110, and no history of a stroke. We're going to determine the risk versus benefits. age of the indication, patients greater than age 75. Do they derive more benefit from the use of thrombolytics? Do they have a greater reduction in mortality? And there are increased risk for complications. And here's a list of thrombolytic agents: protoconase, TPA, the second one, gluconase, and Redox. Now, when I was a paramedic on the Outer Banks, we used Redox. We had Redox in the truck. So, we actually refused a gentleman from Jacksonville who went down to Ocracoke Island and was vacation. He had a big infarct. And by the time East Care got there, he was actually refused back to a normal EKG. So, about 2 hours before East Care got there. So we already had him refused by using Redox. Redox is a very easy administration. 2 doses and you're done. And we'll go over there. So that's the only one I've used as a paramedic in the field of Redox. Protoconase advantages, it's very inexpensive. Has a lot of large clinical trials and less chance of CDA. Disadvantages: hypertension, allergic reaction, and it's non-selective thrombolysis. And the dose is 1.5 million every 16 minutes. TPA advantage is thrombolysis, non-allergenic, and has improved mortality. Disadvantage is expensive and it does have an increased risk of CDA. And the dose is 0.9 milligrams per kilogram, not to exceed 90 milligrams, infused over 60 minutes, with the first 10% of the total dose as a daily dose. Y'all might be transporting someone who's on a TPA drip. Redox, very simple administration. This is what we have in the truck. Very less allergenic. Disadvantage: increased risk of CVA because in a small body weight or elderly with an increased risk. And the dose is really simple: 10 units IV twice. Do the second dose in 30 minutes. There's no drip or anything to it. 2 bowls, once, 30 minutes later, another. Done. Heparin binds to anti-thrombin 3 and catalyzes its activity. It prevents conversion to fibrogen to fibrin. Stops further thrombus formation. Has a half-life of 60 to 90 minutes. And if we get to monitor the iodine. Adverse side effects is thrombocytopenia and bleeding. And of course, the antidote, the antagonist is the protein sulfate. Doses of thromboembolism prophylaxis, 5,000 units sub-Q every 8 to 12 hours. Around the acute coronary syndrome, 60 units. Dosing, non-similar 6 units per case, up to 4,000 units IV times once. Warfarin, Coumadin, inhibits vitamin K dependent clotting factors 2, 7, 9, 10, and protein C and F. Pharmacokinetic has a half-life of 20 to 60 hours, mainly excreted through the urine 92%. Warfarin uses for anterior wall infarction, atrial fibrillation, valve replacement, thromboembolism, and is also used for rat poisoning. So that's Side effects, skin necrosis, hemorrhaging, acute kidney injury, hepatitis, and a cholesterol embolism. Drug interactions. Warfarin has a decreased effect when given reduction of rifampin, phentoin, carbamazepine, phenobarbital, lecitin. It has an increased effect when given the steroid, vaccine, erythromycin, NSAIDs, and alprazolam. This is where when you need to know your drug interactions with the medications. You might need to either increase or decrease the warfarin dosage. But we'll monitor the INR levels for that. Monitor perimeter, international normalized ratio, INR. The goal is the INR to be 2 to 3, and those with a mechanical heart valve is 2.5 to 6. The antagonist will be vitamin K. This is also important for those who take Coumadin on a regular basis to know what foods has vitamin K in it. So anytime you take warfarin, these high, moderate, and low are the content of the vitamin K in that particular vegetable or food product. So as you can see, vitamin K is very high in broccoli, cabbage, kale, lettuce, liver, parsley, spinach, and it goes right down to moderate to low. So those who are on warfarin need to monitor and modify their diet so they won't have an interaction between what they're eating and warfarin. ADP platelet receptor inhibitor. They irreversibly bind to ADP receptors, reducing platelet activation and aggregation with a half-life of 8 hours, and it's free for a year and through the leg. So we have two. We have a flavin and picloxamine. They're used as a second-line antiplatelet therapy, and it's the drug of choice is intolerant to aspirin. Agents are not used for acute interventions due to a slow onset. So usually what we do, we always give them the aspirin therapy, 224 milligrams, and then we'll give them the Plavix in the ED, but the onset of action is quite a few days. So it's nothing quick. Dosage for acute coronary syndrome is 300 milligrams PA times 1, and you give it with aspirin. And for thrombolytic prevention is 75 milligrams daily as a prophylaxis. So aspirin, everybody knows what aspirin is, blocks the carboxy A2 production, inhibits platelet aggregation, and has a platelet half-life of 5 to 7 days. Doses for 325 milligrams PA, and used in acute coronary syndrome, CIA, thrombotic stress prevention, and decreases mortality and reinfarction rate by 40%. Concerning aspirin, I think the ISIS-2 trial showed with aspirin, you had a decrease of rate if you use aspirin alone by 22% for mortality. And then we added to with the thrombolytic agent to increase it up to 43%. With this aspirin alone, it had a decrease in mortality by 22%. So I take my aspirin every night. Glycoprotein 2B3A receptor antagonist. Probably 40,000 to 80,000 receptors per platelet. This drug modifies the platelet aggregation and subsequent thrombus formation. And the example gave me interferon and hydrostat. Interferon pharmacology firstly binds to platelet lipoprotein 2B 3A receptors, reducing platelet aggregation. And it's derived from the venom of a southeastern pygmy rattlesnake. And the half-life is 2.5 hours. Interferon dosage for acute coronary syndrome is 180 micrograms per kilogram IV up to 20.6 milligrams IV per month with an infusion rate of 2 micrograms per kilogram per minute. And then for PCI, 180 micrograms per kilogram IV up to 22.6 IV times once before the procedure, and then the infusion rate at this 12 hours after this. Hydrostat, we reversibly binds to platelet lipoprotein 2B3A receptors, reducing platelet aggregation. And it's derived from the venom of a saw-scaled viper. Onset is 5 minutes with a half-life of 2 hours. So if you have a coronary artery, acute thrombus is something you need to get bit by a snake.
Not any snake, but a saw-scale.
Saw-scale viper, yeah.
I don't know who those are.
I don't know. But we have southeastern pygmy rattlesnake, but you still have to hunt for them.
I don't know if I'm gonna get close enough to know.
That's what I'm saying. And paracetamol dosage is for acute coronary syndrome with a non-ST elevation is 25 micrograms per kilogram IV times once, and then a infusion of 0.15 micrograms per kilogram per minute for up to 18 hours. Most likely, y'all won't be starting the infusion, but you should be maintaining the infusion of whatever the thrombolytic or anticoagulation therapy that the patient is on. Molecular, thank you. Low molecular weight heparin. It's produced by depolymerization of heparin. It binds to the antithrombin 3 and accelerates its activity, inhibiting thrombin and factor X or 10A, which blocks conversion of fibrinogen to fiber. Examples are enoxaparin, oligoparin, and classic anticoagulation, indicates for DVT prophylaxis or treatment. Levodops, DVT prophylaxis, anybody who's admitted to the hospital with Levodops, you just need standard thing. 30 milligrams sub-Q every 12 hours for the prophylaxis, and of course, they're being treated with 1 milligram per kilogram sub-Q every 12 hours for treatment of DVT or pulmonary embolism. For angina unstable, 1 milligram per kilogram sub-Q every 12 hours and give it back.
Is that for your list mobile and you want to do
So, it's that.
They put some things in my list, too, don't they?
Compression socks. Compression stockings, yes. That's actually a pretty good course. You go online, but you take it and you can actually see me on it. Can you copy that? No. I don't know how. I do know how, but I'll get it to you. Figure out how to do this first. Neuromuscular blocking agent. Blocks transmission of neuromuscular signals resulting in skeletal muscle collapse. And it's most commonly indicated for facilitating endotracheal intubation. Y'all do RSI here? Where you at?
Family County.
Salmon County?
I'm on.
Richfield?
You got Richfield. Yeah, a little bit of Richfield. in Salmon County.
Okay.
You came through.
I come through Richfield last month. Yeah. We're proud.
Yeah.
I stopped there at Taco Bell to take a picture.
Yes, sir. Right there, 52 and 49, that's in my area.
I don't know where
I'm
it's at.
picking up what you're dropping. I'm smelling what you're stepping in.
I'll make sure I won't go that way again if I get in there.
Well, I'm not working.
You won't
nights,
be
so-
there. Okay, might be safer. Quick overview of muscle contraction. Acetylcholine released from the synaptic cleft binds to the receptor on the motor enclave, causing a depolarization of muscle fibers. Acetylcholinesterase limits the binding. It's a big deal. Especially in your mouth. Events in the excitation contraction coupling. Contraction of a skeletal muscle fiber is initiated and maintained by the arrival of action potentials of the axon terminal of the motor neuron. When the action potential ceases and calcium is transported back into the subclavian reticulum, the contraction stops and the muscle fibers relax. Got that? Now you have to draw it out. I have a picture of the excitation contraction coupling, as you see in number 1 in the top middle. Okay. Axon terminal, which is that the flap. The pole, you have a neurotransmitter released to the fuse across the synaptic cleft and attaches to the acetylcholine receptor on the sublimit. And then you have an action potential, which is generated and propagated to the sublimit down the two tubules. You can see it coming down, which causes a calcium to be triggered, releasing from the terminal system of the sublimit. Calcium ion binds to troponin. Troponin changes shape, removal, and the blocking action of the tropomyosin actin site are exposed. So you have a contraction as the myosin cross bridges already attaches to the actin and detaches, pulling the actin fiber filaments towards the center of the sarcomere. Release of the energy by the ATP. And then you have the removal of the calcium by the active transport after the active potential ends. And then the tropomyosin blocking restores blocking active activity site and the contraction ends and the muscle fiber relax. So all that happens really quickly. So with neuromuscular blocking agents, we're blocking the acetylcholine release of the synaptic cleft. So you don't have that action potential generated on the CT. Type of neuromuscular blocking agents, you have a depolarizing and non-depolarizing. And the difference between depolarizing and non-depolarizing. Depolarizing, you will have a neurotransmitter that's going to mimic the acetylcholine and activate the potential, and then you'll have your cisplatin muscle until all these sites are filled up, and then it will stop. Where the non-depolarizer is just on blocks, you don't have the effect at all. It mimics a good bit. Thank you. Acetylcholine, the depolarizing agent binds to the acetylcholine receptor, causes persistent depolarization of neuromuscular enclave, causes muscle weakness, and metabolism terminates activity. Pharmacokinetic, Onset is 1 to 1.5 minutes with a duration of 5 to 10 minutes. Metabolism is plasma pseudopolymerase. Dosage is 1 to 2 milligrams per kilogram, 1 time, and it's used for rapid surgical intubation. Some of the adverse side effects of flux is hypertonia, muscle fasciculation, increased intracranial pressure, increased intraocular pressure, bradycardia, or tachycardia, respiratory depression, malignant hyperthermia, and cardiac arrest. Here's the oral paralysis after administration. Start from the eyes, face, and neck, down to the extremities, abdomen, and intercostal glottis, and then following these guys. To a non-depolarizing agent, an antagonizes motor impulse acetylcholine receptor. And here are the agents that we use: methane, Paglon, and Braswell. Chemotherapy facilitates intubation, synchronized mechanical ventilation, prevent extubation, decreases intracranial pressure, reduces metabolic demands, acute respiratory disorder, and minimize oxygen consumption. Pulmonary onset 3 to 5 minutes, with a duration of 60 to 90 minutes, and it's limited to the renal unit. Dosage is for endotracheal intubation, 60 to 100 micrograms per kilogram, IV times once. And for neuromuscular blockade maintenance dose, 50 to 100 micrograms per kilogram IV every 25 to 60 minutes. Adverse effects: bronchospasm, tachycardia, hypertension, diarrhea. Nickelon has an onset of 3 to 5 minutes, with a duration of 20 to 40 minutes, and is mainly excreted by the liver. Loading dose: 80 to 100 micrograms per kilogram per IV in conjunction with subs to assist with intubation. And for neuromuscular blockade maintenance dose, 0.8 to 1.2 micrograms per kilogram. And then start the infusion rate after the injection. The running adverse effects: muscle weakness, bronchospasm, prolonged paralysis, and respiratory depression. Criticism has an onset of 3 to 5 minutes, with a duration of 20 to 45 minutes, and it's then excreted to the liver. Loading dose is 400 to 500 micrograms per kilogram per IV, with a neuromuscular blockade maintenance of 5 to 9 micrograms per kilogram per minute. Adverse effects is malignant hyperthermia, bronchospasm, hypertension, seizure, and skin flux. As you notice with the depolarizing agents and the non-depolarizing agents, the most biggest thing that you see is the time of duration for the duration of paralysis. Such is a depolarizing agent that have a short duration of action. That way, as EMS providers, we administer, can't get it intubated, You can always bag them for 5 or 10 minutes to come out. With a non-depolarizing agent, they're noted are 30 to 60 minutes in duration. It takes a long time. You can't get somebody into bed to sit and try to bag it out. So EMS is pretty much sticks with stuff. Patients who had prolonged paralysis, they end up having some renal failure, drug interaction, and elderly people because of their metabolism and other comorbidities, they can have prolonged paralysis. Most of the medications that we saw are renally excreted. There's a few that are hepatically excreted. So if you have any type of renal failure or hepatic failure, you can be prolonged paralysis. And then you have some anti-inflammatory vascular stuff. And then you got some drug interactions between the two. Potential blockade, meaning glycoside, aesthetic, magnesium, lithium, and verapamil. And then those that inhibit the blockade, Zantac, corticosteroids, synthorm, theophylline, and carbamazepine. So if you know if you're on taking any of those medications, you might have to increase the dosage if you're on magnesium or lithium. If a blockage, so you might have to increase the dosage so they can overcome that. Patient care issues. Anytime you paralyze somebody, you still got to think about them. Even though they're paralyzed, they still got pain and anxiety. They can see everything that's going on. They just can't move now. So you need to take that into consideration. Make sure you do good analgesics for any pain, any type of sedation for the anxiety. And then, of course, we're also going to have an increase in possible DVT and ulcer formation due to the inability. So you need to take that into consideration also. And then, of course, one of the biggest lawsuits that we hear of is especially pointing at raises and stuff, and eyeliner and stuff like that, because they can't get the eyelids shot. So a lot of times you need to close the eyelids with paper so that the eyelids and the eye itself will stay more dry. Yeah. You think? Of course, the patient is trying to do that's why we're treating you. And anytime in the critical care and hemodynamic monitoring, anytime you have to intubate somebody, you make sure you have an internal continuous wave capnography, nasal administrator, neuromuscular blocking agents to confront and monitor any of this patient here in the transfer. Anybody want a break or you want to continue? Break?
Oh. We can, looking for a bag with coins. Nothing in your bonding. Yeah, for one of them. Just FYI, female's been in this 25. And you've been in my class probably 25 years. You probably been classes directly. You remember what your first class was? I think I do, but I don't. We want to think of it as we have to go through the legal at Lamar. That's the first thing we do. So, you know me more than that, but yeah. So here's the deal, there's a full call instruction. Get a hold of it. But what I'm really doing is the most is, if you think I've been coming to pre-med class any length of time, and you come back to a second class from the anniversary year. No, you're getting it. For less than I paid for, no problem. It's solid. So let's see. Steve got one, Eric got one, Eric, you got one. Rob, you don't have one. Rob has to come back to something this year before December.
Is there anything?
Well, ICLS, Advanced Stroke Life Support, PED Trio, AMLS, that's all the way down the end of July. Fancy Moreland, you can get this care, please. Get one from here. Yes, personal. You want one thing? Eric? Is it? Just some of the classes that are coming up in the next couple of months. Sure, sure. We have more that we haven't created flyers for you. We know. So you bring a man stroke. Eric works at Hyde now. What year did you go? I was there is I was very small. Okay. When did they have that big hurricane? That narrows it down a bunch. What happened was I was on paramedic and then we went over there help I told me out and yeah, she wasn't even a paramedic at all. I thought, yeah. So I put it on YouTube tonight. Sure, or he'll put it on Google tomorrow. Oh, we have a test. I think it's on Google. Sure, you want to get the movie? We did a pre-test, and then eventually we finally put it out.
Get your line back in.
And then they probably so. Yeah, that's right. Oh, I never had to do it. Oh, isn't that cool? Yeah, right. I'm close with those.
The month of May, there were 31 homes. And my dad, four sons. So he's like, okay. Yeah. They're not students. I had to, I had to pay $204.
Yeah, that last one, I was like, you know something that I don't know?
So they'll just give me $200. No, sir.
I'll take it.
No, sir.
You can never have to do that.
I did not say I could have too many. I said I don't need them. I don't have more.
How many is 2 months?
There's not a 2 many. There's enough. I have enough.
I mean, I have enough too, but I'm trying to figure out if do I have too many? Because I have quite a few. That doesn't matter.
But if they did one, the kid is not.
I have them outside the safe, but I can't put them on.
Still not.
It's not too many. I have somewhere between 60 and 70.
No, I don't have that many, but I have close to 40.
Oh, I've had 40 for years. I got 2. Bro. Yeah, I got 2 seats. I got a 220 and 365.
I got more to try that.
Because it shoots up at 21 feet.
It does.
No, Robin, but it's the points where yeah.
I tried to come tonight and I trust to take it to the range.
Hell, I'll take you to that range.
My dad's got my mom's head burning. So I'm scared of those. Like, I'm not scared of them, but like, I want to make sure that I know how to properly handle them. And I'm not really sure how I'm going to react to it.
Well, guns don't kill people. People kill. But well, nothing bullet doesn't kill people. I've got a whole bunch of bullets in my house, and not one of them has killed me yet.
You know, see a man?
That too.
A legal person.
You can't treat stupidity. My God, I can stay in his face.
I can shoot shit.
Yeah, stupidity.
This is true. Very true.
You don't use enough time off to be intervening.
I wish I was in Georgia. I lived in her.
I haven't received your pre-test back. I must have left them.
Hotel, motel, holiday.
At the home.
So I will scan them and send them back. But yeah, I recognize you are correct.
Well, I got to point all 5 minutes. I thought it was like some people. But why you gotta be like this?
This man right here is the one that we play like that.
Vegas style, not just like, I had 4 decks of cards. So that, you got them.
I didn't have any photos. We didn't have the order. Or she.
You don't have I don't have a shoe. That's what.
I put my stuff.
That crash. That. Yeah.
This old man.
Right? We will continue with analgesics and sedatives. Analgesia. Anytime you have pain, it affects part of your body system, increases the sympathetic outflow, has a catecholamine release, tachycardia, increased respiratory rate, hypertension. Analgesia is the insensibility to pain without loss of consciousness. And we always have that one patient which we use a hand on, or a spouse. Or,
Why are you looking at me?
yeah, he was like he wanted to hit you in the head.
Oh. Okay. So
All right, Toradol, Ketorolac, the non-steroid anti-inflammatory drug. Pharmacology, exact mechanism of action is unknown, but it inhibits oxidase, reduces prostaglandin and reboxin synthesis. And the excretion is primary through your urinary system. So those who have renal insufficiency or renal failure, we usually don't give Toradol. Dosage is 60 milligrams IM times once, or you do an alternate 30 milligrams IV once. And older patients, patients 65 years or older, we do reduce the amount to half to 50 milligrams IM or IV one time only. And renal impairment, 30 milligrams IV or 50 milligrams IV, and it's contraindicated in advanced renal disease. You don't care toward all of it, do you? Yeah. Okay. Y'all use much of it, or y'all go straight to the opioids?
I got somebody having a kidney stone, by God, that's what it was.
We do, kidney stones it's great for kidney renal colic and everything. We usually get morphine and Toradol. The morphine will go ahead and help with the pain, you know, knock the pain out, and then the Toradol is more slow acting, so it gives you a longer duration of pain control. So yeah, I do both one time. Kidney stones hurt. Opioids, pharmacology, they bind to the opioid receptors in the central nervous system. They alter the perception of pain, and they alter the response. And this is what EMS loves to do, give out opioids. You give it out like candy? We do have a ED physician, and he gives out a lot. And when he's working, we have more people come into the ED with pain. So he has a real big red truck. You can't miss it. It's a big ass red truck. Then we'll actually see him drive through the parking lot so he's working when they come in. They see the big red truck. We have more influx of patients increases because of sky pain, dental pain, any kind of pain. And he's a pain for us. You gotta keep the customers happy. Keep them coming. Morphine sulfate onset 15 to 60 minutes with a duration of 3 to 7 hours with a half-life of 2 to 4 hours. And it's distributed through the renal system. We always go by the morphine equivalent. I'm sure everybody seen this chart before in the cath and everything like that. But this chart is showing the equivalent of other medications that has the same effect as morphine does. So if you give morphine as an oral pill, a 15 milligram dose of oral pill is the same thing as if you give it Dilaudid oral at 4. So it has the same effect. Or oxycodone at the same. You understand how the chart works? The morphine oral is oral dose is 50 milligrams. The opioid middle is equivalent is 15, which is close to 1. So if you give hydrocodone as an oral tablet, it takes 10 milligrams of hydrocodone to do the same effect that takes 15 milligrams of morphine. And we're going to do Dilaudid. Up here, Dilaudid on the truck. And so if you gave oral 4 milligrams of Dilaudid orally, it's the same as giving 15 milligrams of morphine. Discharge. That works for discharge.
Diphenhydramine works really well too.
I had a patient in Surf City. He presented like a renal colic, I think, pain. And he kept being, of course, he was Hispanic. I don't speak Spanish whatsoever. And the only thing he was doing was like this. So I started my IV and did my last saline flush. All we'll do is saline line. And as soon as I flushed it, he goes, relax. And that was just a saline flush. I never gave you the first pain medication the whole route to the hospital.
What is what?
So I get docked with this all the time. But they monitor how much morphine equivalent medications we give out as a PA or physician or whatever. So every quarter I get a big thing of how much morphine equivalent medication I can give out. And if they want it between this and that, it's kind of regular. At the end, if you come the first of the month, it's good. I'll give you something. End of the month, yeah, I'm sorry, I'm already used my allotted time and whatever. So. There you go. Don't take much.
Oh, God, yeah, I had a big thing of pickle patties.
Sure
Put
does.
them in tea, heat them in the microwave and drink it.
Well, that'll work. I mean, point.
He died.
Y'all carry fentanyl on the truck?
Yeah.
Yeah, we need to put down the morphine and fill that food.
Of course, we got that. He had no idea what happened.
But that's just a quick charge to the morphine equivalent of different medications, and they sort of relate everything to the morphine. This is on the test, so just remember that. 1, 2, 3. Morphine sulfate dosage 2.5 to 10 milligrams sub-Q, IM or IV every 36 hours. And he says that for pediatric dosage 6 months to 12 years old, less than 6 months. Okay, now, on February 2nd, with a duration of 1 to 2 hours, with a half-life of 2 to 4 hours, and the speed limit to the minute. Dosage 50 to 100 micrograms IM or IV, every 1 to 2 hours administered with the alternate dosage of 0.5 to 1.5 micrograms per kilogram. I think someone mentioned earlier about a lot of drug overdoses and stuff that bad we cut with fentanyl and stuff. And we're seeing we actually had one last week. That's the one I think someone mentioned about the IO earlier. Talking about IO, EMS for the IO info. We've got our back and everything because we discharged it and you think that we had a 4-hour. She didn't like that. But this she wants something for pain. No. I don't know. I don't know. So we're seeing a lot of fentanyl over there.
Stanley County, number 1 in North Carolina. That's right.
Hydromorphone binds to various opioid receptors, producing analgesia and sedation. Has a duration of 3 to 4 hours with a half-life of 2. Yeah. And it's mainly to the renal system. Dosage 1 to 4 milligrams sub-Q, IM, or IV every 3 to 6 hours. Try to use the lowest effective dose and titrate slowly in patients 65 years of age. If you don't want to overdose them already. Demerol, not used much anymore, but we still use it. Binds to various opioid receptors, producing analgesia and sedation. Duration is 2 to 4 hours with a half-life of 2.5 to 2 hours. And it's excreted through the urine. Oh, I'll give it out. First of the month, come see me.
We don't have it every year.
Dosage for moderate to severe pain, 50 to 100 milligrams sub-Q IM every 3 to 4 hours is needed. IM is preferred over sub-Q, and for the decrease your dose is given intravenously, and body to use in a minute to stay. And then because you use a lower dose than others. Because then won't get very much.
Yes.
What's considered elderly? 40.
She's like, she's probably that.
You're 39, so.
I'll never see 40 again. So. Some of the adverse side effects of opioid administration causes respiratory depression, we see that a lot, respiratory arrest, sedation, hypertension, constipation, and nausea, vomiting. And we actually see a lot of people come in constipated all the time because they're taking their Norco or oxycodone or something like that, and whoever prescribes it to them, they'll never tell them to take a stool salt. So we have a lot of people with abdominal pain and they're backed up. So, yeah. And of course, here's a chart of the breakdown of opioid deaths, because this is a map shows the death in 2016. I don't have to on it. You see wherever county you're at. So, I don't know where I'm at.
Y'all don't know where you are? The bottom. The bottom one that looks, I don't know, it's sort of like a weird triangle with a flat top. Bottom side. Yeah.
Oh, that's where you're at?
Yeah, that's where you're at. Right now.
That's where all that stuff is. So what's this? That one is that's Mexico.
No, that's Lincoln.
That's Lincoln. That's Iredale. That's Mexinsburg. That's Cabarrus next to.
So that's Iredale, that's Cabarrus.
Oh, Cabarrus is to the right. Right there is Cabarrus. That's right.
Rutherford's over there. I ain't ready.
That's Rutherford. That's Polk. All right, so now where's Hyde?
Well, this is part of the county here.
Yeah,
That's going to be, this should be high.
that could be Hyde.
Because
So when if Elbert or Eric are on Poke Island, they work a 72 straight.
Right.
We call them on stop 7 day week on the island. Okay.
Did you run how many calls?
3.
We ran more. We ran.
Yeah, sometimes.
Some of my worst calls overdose is you think it'd be sometimes but the worst calls we had were in the winter.
And it's from there to the island, a 2.5 hour trip. There is no road.
You got 3
To-
ferries.
To the mainland from a.
You got more than that.
You got 3 ferries. You got Swampco Ferry, you have Cedar Island Ferry, and then Harris Ferry. That's it. Or go by plane or a boat or something like that. I mean, another personal.
So this county right here is Carteret, right?
No, Carret's down here. We're in the dark blue. We're way down here. No, we have a lot of
Not Carteret, not Carteret.
not Camden.
What's that? Currituck County.
Currituck, yeah, that's Currituck.
Currituck County. So if when you're watching Weather Channel and they're talking about hurricane landmarks, they'll always say Currituck Island. So it's on the outer bank, not on the mainland.
And you got Dare County.
Dare County becomes its own
County.
own helicopter. County owns the helicopter.
Yeah.
And they are not unbusy.
And they're so good. So just look at where you're on the map and you see the breakdown of opioid deaths by using your phone. And I guess the ones in white have a pretty good zero. I guess EMS does
They're
good.
underreported now.
No, EMS does a good job and they get everybody back because of that.
They're extremely rural too. So this county right here is Cherokee County, North Carolina.
Right?
And Jimmy Amos, that was in class on Airway Day, that's where he's from. This is Graham County. It's one of the least populated counties in the state. So that would be why they have a little near zero. So all these white counties are really, really
Rural area.
rural fucking areas. This was when you get it, when you get now we'll be here.
Your other left knee.
That was the bell. The one straight above it.
is to water the, that's a, it's very small. They're real small, very real areas. Yeah, I'm really surprised that they have it.
But due to their low populace, they
Yeah.
only have.
Per capita, right.
Per
Per capita,
capita,
yeah.
is why it's dark.
But this is not per capita.
But it's per
Per
10,000 people.
But Boone is also close. It's gonna be a big weekend that AIDS. Contribute something else.
So with all the opioid deaths in the county and including in North Carolina, for my job position, regulate a lot of writing prescriptions for drugs. The DA and stuff like that. We are limited on a certain amount that we can write in the emergency department in like 3 days supply of North Carolina. Even if they came with an open fracture of the leg or whatever, you get 3 days and that's it. And then you need to follow up with an orthopedic who will give you more medication. So, they should be, but we don't have a lot of people who follow another file. Just keep coming back to the yeah. But with opioids and opioid overdoses, you've got to speak about Narcan. So. Yeah. Narcan is opioid antagonist, onset 2 to 3 minutes with a duration of 31 to 90 minutes. And it has a half-life of 1.5 hours. And it will reverse all the opioid effects, including pain control. So once you take away the effect of opioids, if they had a broken leg or anything, whatever, they're going to be in pain, but ever getting pulled all or something like that. A lot of times when we have people who come in with overdose of a lot of narcotics, on the formulary list, we're writing prescriptions or prescription Narcan to take home in case damage and someone needs it. We give it away. Yeah, I can't give it away from the ED, but I can write you a prescription for you to go get you some.
Well, whenever we wake somebody up, we have paramedics. That's their focus in Stanley County.
Right.
And they will give away I think it's the 4 milligram.
Which is a good thing. That way but
Yes and no.
I tell you, I know where I feel about these things, but I can't say that.
We are.
I have a disclaimer going.
We are absolutely the enablers by doing this.
Yeah. Yeah.
But.
Mistakes.
No, in
One,
occasion,
two, maybe 3 times back to that.
no, occasionally we do have those accidental overdoses and stuff like that. It was a legitimate accident. Yeah, we were actually with the accidental thing, but then you had those ones who literally do it.
They have Narcan parties.
Yeah.
Yeah, some of these people have a Narcan parties. See how much they can get high at Narcan.
The problem is you have 2 people get high on it, they'll get passed out and you're going to be able to give another thing.
I ran an overdose and all the friends there wouldn't tell me what he took, but the first thing they said, give me the parking.
Yeah.
Come on,
Yeah.
Oh, I don't think you do that. Well, we gave you Narcan.
So Narcan is the opioid antagonist. We all know what it's used for. It's also 2 to 3 minutes. Duration is 30 to 90 minutes. And depending on how much narcotics they take, you might have to re-administer the Narcan 2 or 3 times with a half-life of 1.5 hours. Dosage 0.4 to 2 milligrams sub-Q IV, 2 to 3 minutes as needed, or you do 1 milligram each doctor form. You injectable for the new face. And now it's time to start sleeping through class. Late afternoon, everybody have their long. Everybody eat the day. We all eat on the way home. So sedative. You all like sedative? Makes you feel good? Make you sleep? Good sleep. Agitation is defined as a state of excessive psychomotor activity accompanied by increased tension and irritability. And so the reality can be agitated by hypoxia, pain, spouse, sleep alterations, withdrawal. I keep that's basic. I do that in.
Okay.
And of course, there's always withdrawal. I call it opioid benzos. We need more coffee. Grab this coffee. ICD psychosis. ICD psychosis is a form of delirium or acute brain failure. Organic factors include dehydration, hypoxia, heart failure, infections, and drugs can contribute to delirium. The increase in incidence 10 to 15% with individuals over the age of 65, and it's a diagnosis of exclusion. You have to rule out everything else before you can say that we have ICU psychosis. Usually in EMS and emergency department, they'll be admitted to the hospital and they rule it out upstairs. Goals for therapy: prevent harm for patients and others, alleviate discomfort, avoid toxicity, and help to improve oxygenation. Haloperidol, y'all carry Haloperidol in truck? It's selectively antagonize the dopamine D2 receptors and is a high potent neuroleptic. All set 10 to 30 minutes with a duration of 2 to 6 hours with a half-life of 21 to 24 hours. How often do I use Haloperidol? Do I use it all? I use it. Perfect. So it's a major tranquilizer. Haldol, dosing for agitation. You got mild, moderate, severe agitation. You go from 0.5 to 20 milligrams, depending on how you rate it. Give initial dose of IV, and you may repeat it 30 minutes for agitation control. And you need to take it, y'all won't be concerned about that, but taking the dose every 2 to 3 days, gradually to this way. That's one thing I like about EMS. You fix them, you drop them off at the hospital, and you leave. And I'm stuck with them. I just can't do it. Yeah. You work at? I'm a hero nurse. Okay. Yeah, we're stuck with it.
You always wait to give, 2 Narcan right before you pull up.
Or as you put them in the bag.
Yep.
Haldol adverse effects: breathing prolongation, acute dysphonic reaction, hypotension, neuroleptic malignant syndrome, and sedation. Any questions? Now you have anybody have a question. Neuroleptic malignant syndrome is a life-threatening, characterized by fever, altered mental status, diaphoresis, muscle rigidity, and anatomic dysfunction. Neuroleptic malignant syndrome is most commonly linked with the use of antipsychotic medication. This is something to be aware of.
Not another question. I know video for EPS reaction, but with the female stuff, potentially.
I think it's definitely what you use.
For this thing.
I had to double check, but I think it's the same thing. Benzodiazepines, gadolinium-mediated inhibition of pre- and post-synaptic dopamine, and the effects of anxiolysis, sedation, amnesia, and skeletal muscle relaxation. The same doctor who gives out all the narcotics, who doesn't give out values for muscle. So now he has opioids.
So what you saying is
Yeah, and look for the big red truck.
First one.
first one,
No,
BRD, big red truck.
big red truck. And it's a diesel, big red diesel truck.
BRD.
Just don't be somebody to sleep on it. I thought it was Steven and be mine and something else. I hate that.
First in, short acting, onset 1 to 5 minutes, with a duration of 2 to 6 hours, with a half-life of 1.5 to 3 hours. And it can be prolonged up to 12 hours and 2 years, depending on what the underlying ability is. Dosing, depending on what you categorize it as, mild, moderate, or severe, anywhere from 1, 2 milligrams to 7 to 10 milligrams. And you can do it continuous infusion of 1 to 10 milligrams. Just a dose.
Somebody joined the meeting. You just joined.
Low battery.
Okay.
It's me again. I got knocked off.
Okay.
Lorazepam, Ativan, intermediate acting at the onset of 1 to 5 minutes, with a duration of 6 to 8 hours, and a half-life of 14 hours. Dosing anywhere from mild to severe agitation, anywhere from 0.5 to 4 milligrams. And the maximum rate is 2 milligrams per minute, and may be given as a continuous infusion. Diazepam volume. Long acting, onset 1 to 5 minutes, with a duration of 20 to 30 minutes, with a half-life of 20 to 80 hours. Dosage, moderate agitation, 2 to 5 milligrams. With severe agitation, between 5 and 10 milligrams, with a maximum rate of 5 milligrams a minute in infusion. Benzos, adverse effects, respiratory depression, hypertension, bradycardia, excessive sedation, and venous thrombus. Risk factors include elderly, hyperkalemia, increased dosing, and liver infection. And just like with opioids, we have Narcan, and with benzos, we have Remazepam. Remazepam is a benzodiazepine antagonist with the onset of 1 to 2 minutes, with a duration less than 1 hour, the half-life is 40 to 80 minutes. Yes, sir. Yeah, yes, sir. A lot of times we'll just put them on a ventilator or something, just, just bag them and just let it wear off.
I'm wondering, like, would now, have you certainly have received Mazepam?
I mean, seizure prophylaxis for clamps and straps.
I wonder if it would do anything.
If you're at that point, you can sure try it. If you're last resort, you know, 2 to 4 milligrams. Grams, 2 to 4 grams of IV. It ain't gonna hurt
I
nothing.
mean, we don't care what Mazepam, so it's kind of important regardless.
Right.
However,
Yeah. Personally, I don't think EMS should have it on the truck. Because of, you always have possibility of decreased seizure activity after doing it. But yeah, just bag them, put 2 in, be happy. And you don't have to worry about them fighting. Just go out. So Mazepam dosing, reversal of sedation is 0.2 milligrams every 15 seconds. And you repeat 2.3 milligrams in 30 seconds for the max dose of 5 milligrams per total. And then your overdose is 0.2 milligrams every 30 seconds. And you can give 0.5 milligrams every minute up to a max dose of 5 milligrams. Adverse effects, you can have withdrawal from the benzos, increased seizure activity, as we just called about, sedation, and arrhythmia. Propofol, this is sedative, hypnotic, for induction and maintenance of anesthesia or sedation. Onset of 40 seconds to 1 minute, with a duration of 5 to 10 minutes, with a half-life of 1 to 3 minutes. So it's pretty quick on and off. Turn on, turn off.
First to run.
Used for general anesthesia induction, with healthy adults up to 55 years old. 2.5 milligrams per kilogram IV given as a 40 milligram IV every 10 seconds until induction onset. And then you do a maintenance dose of 100 micrograms per kilogram per minute to maintain 2 days. Adverse effects, hypertension up to 30% of the individual, bradycardia, pulmonary edema, thrombosis, and cancer. Accommodate is a short-acting, non-barbiturate, intravenous aesthetic agent with hypnotic effects. Mechanism of action may have GABA-like effects, depressing brainstem reticular formation activity and produces hypnosis. And it's used to facilitate intrathecal intubation and advanced early management. I'm sure we all have accommodate. You don't have accommodate? You don't do RSI, that's right. Accommodate onset duration occurs within 30 to 60 seconds after IV administration. And you leave the patient awake from the injection dose within 3 to 10 minutes. And 0.1 milligrams per kilogram boluses will provide 100 seconds of sleep. You do 0.2 mg per kg, you do 200 seconds of sleep. And it gives you 200 seconds, 2.5. And it's short acting. You can always bag them out of it. But they'll breathe on other to give them the sucks. So, it's in our facility, it's physician preference. Right. So whoever they want, like the doctor, the big red truck doctor from the old school, but he really said I didn't make a parrot. It all depends on whoever the ED doctor is.
You use accommodate if they're hypertensive, if they have some bronchial issues.
It's nice to have blood work back. I mean, well, in ED, sometimes we need the chemistry back. Whether they want to give them soap because of what the potassium is. Right. If the potassium is really high, but you don't want to soap it high, so you might want to go with non-polarizing ED.
You got a lot for that.
Yeah.
But
We do not. Yeah. As soon as you get that little lab in the back of the truck, do these chemistries. See what you do. So, accommodate, pretty fast acting. Some of the adverse effects to accommodate myocardial movement, hyper or hypertension, brady or tachycardia, nausea, vomiting. What?
Something I like the admin part, especially when it's better.
And of course, the dosage to accommodate is 0.3 milligrams per kilogram, per kg, rapid IV push. And then you can do a second dose of 0.3 milligrams per kilogram, rapid IV push, 57 will be initial course. Quick 5 minutes break, I need a drink.
There's more being free.
Oh, this is what I.
You're not here today, my machine running 24/7? It runs 24/7.
We'll be out here by 7.
Okay. I heard Joanne and they said that RSI full. Each RSI.
Tell me more.
They full. I don't know why. I guess strategy something.
What'd you say, Glenn?
I said, you said I was hollering at you.
Hollering. You was hollering at me when I signed on.
Oh.
Lord have mercy.
Where did you see him?
Listen, we have a little paper. They nurses.
Much of they are nurses.
I know you love nurses, but those people.
Do what?
He's definitely.
You know, from the ER, the nurse is like, oh, you just won.
I swear, it's one of the nurses that eat and stuff in my bag. We walk in. I go in there, fly across the street, fight and get me out of
I'm always like,
Yeah.
I'm always the one.
oh,
Also,
actually.
Ask him what time he's gonna get together. You'll probably be the speech. What time do you get? He's already there. Where's that?
We had one in that. I went in one time thinking they had that on my break. I said, they have like essential oils and little. That Canapa CR. We had a couple nurses that did this aromatherapy, stuff. So they wanted to create that little room to get away. We're having a bad day, go in there, sit down and clear your mind, and they have the lavender going, and little rock laying out, and the music going, go in there and relax.
It sounds like you've been doing a lot of massage.
That's what
I did not know that was possible.
We want to get president. Gary, when you make your president.
I had no, yes, my boss man,
You don't give a shit.
he does for the shit.
You care if you guys get the president right now? You want to respect that? Not that? But we'll be done in time for this. Shut it down and go home. Get the answer?
Whatever way.
Okay, I can say, you ask his best BFF, you ask her or me. How much you care? Don't expect people, I said, you tell his BFF, you answer her or
What do
me.
you want? What do you want?
Is he here yet?
Oh, no.
That's all right. Elbert texted me this month.
I think he had work though. So probably not. It's like noodle, the way they eat.
Hey, I have a condo in
How much is the rent?
Okay, how much is it for me?
What do you not say that?
Elbert,
I'm super long.
don't worry about it.
You don't go to the property.
You know, we want to see the heat.
Really?
Oh, yeah.
I've never been. I
It's
don't know.
legal.
It's legal.
It is legal in the county.
I know, but that don't make it good. Decent.
Yeah.
They have to
They have to do it every month.
once you go outside. So if, here's the thing, if it was small, if they were small,
They have man on man, man on woman.
if this was smaller, it would be their, so you can walk down the street, they'll cut their, business cards with a little brochure, that you can scroll through. I'm not gonna say the name, I went to the state district, to the national. And, our stuff came out of the. Anybody got changed for a version? He goes to the room next door, it's changed, it's too big. He comes back and says, anybody have changed for 50? Anybody got? I'm really sure. He goes to start teaching. I start teaching. I read it in. What's so important to you change for 50? Well, what's back in the room? Let's go there off the play back. I would think. So we all know it's good. Second was back in the middle, so I'm saying, over the other right there. First time, man, we all about there.
Your bus not you.
Sure enough, she's staying there. We all staying there, she was there. The police. I was over.
I already know that. But yeah, first person.
And where were you at? Ashton?
Yeah. I don't even know.
Bradley was drafted, Bradley. Oh, no, Bradley was not. Bradley was not the instructor.
Bradley was there?
This, I say this guy is, he's senator,
A whole bunch.
senator for the state.
East from here is
There's a lot of east of here.
I know. Are you talking about east or down east? It's a big difference.
You don't know the difference.
Down
Down east is Beaufort, east of Beaufort.
It would be the Sand Hill part of the state.
Okay.
This is the.
All right. Trying to, lost my mouse.
Back on the screen.
Maybe I can't,
That's all.
I know, but it's not moving on my
And what did my iPad say?
Unable to access camera. I got to figure out how to get to
This is the same way we do it. I mean, if somebody's moving. Just so that I may not be in that area. That time of day.
I can't tell you how many times I've had that administrative. Sometimes with, sometimes without lighting.
I mean, I don't plan on doing that, but if I ever do it, then
who knows computers?
What? Sometimes, remember, I've already been to treat the same person several times before we come back.
okay, well, I had to do it, so.
Okay, well, I'll reconstitute it right. Okay.
Well, obviously, first around it.
First time.
So wait a minute, what's the live thing?
It hurts.
What, you already done?
No, it didn't see your ass.
Oh,
And then if they, and then if somebody's got, if they got tricked.
You know anything about computers?
They get 2,000.
I can move my mouse here, and I'm looking at my PowerPoint presentation, which is not there. But huh? Right, but I wanted to blow it up, and I can't move. But my problem is I can't. I don't see my mouse here at all. You know anything? Anything?
which one do you want to do?
Hey Glenn, I need help.
Okay, I have to go tell this other girl. Who's like, to bring the room down. Ugh.
Hey,
That's awesome.
I had one. I did a pelvic thing. I swear it was like a waterfall.
Yeah.
Just pouring
Yep.
out. It was nasty.
Blood or what?
Guys go this way.
Oh.
But this is what I want to show. See my little mousey?
Yeah.
I can't get it. I know it's so mousey. Okay. You know what I'm talking about?
Provider is female, I'll believe in the pelvic, but if their provider is male, then policy is that one person has to do it.
We have a
Yeah, I have to
we have a male nurse. He always signs up for women. But he don't have women.
I'll go in, if I have a female provider.
We only have one female provider, most times it's men. He'll sign up for it, knowing that he don't do the work on it.
Actually,
I mean, it's still this far. They didn't have to go in and do.
she opened her
help.
up, they go, I'm like, oh,
Like I said,
I don't care, I put my shit up. I had a kid, I put it well, whatever. I'm like, that's not what I was thinking. That's not what I was thinking. It's gonna be big. She shot me, that's something in my ass, man. And then, okay, I always say, I'm not going to put one. So, I got my skill. So, they called me like 3 times. So you got any work? And so she was like, People look at my dog. Okay.
Not everybody.
Well, my doctors.
I'm not a gynecologist.
What's it called if they give you the thing, some days they
Hey,
what's it called when they do,
Fluconazole. Fluconazole. Fluconazole.
gynecologist,
How many times I fluconazole?
I was,
Fluconazole.
I thought, gee, I think all that, I'm like, oh, boy. 3 days later, I wake up. If I could have took a full dose, oh my God, I so relate. I've never in my life, that's the only time I have ever. When I tell you, I mean, that's spitting on shit right there, okay? Like, you know, I will shoot you up 200 people. I got to keep it raw. Oh, dude, that shit was bad. Bad.
All right, did you figure out how to do this morning?
Oh,
Me?
No, him.
Tim?
Yeah, you did.
I mean, I'm back here talking about sticking the clothes up my
Hey, now you
Just chill.
get the number there. It's not, that wasn't the problem. Once I get it, the mouse on the screen, I can blow it up with the screen. Click on that.
Antimicrobial therapy. Okay.
All right, now, where's the mouse? Okay, there you go. Bring it down there and click right there.
Okay.
Now click. There you go.
Bingo.
I don't know how you but yeah, that's it.
I don't know how we did it either.
Yeah, get rid of them. 6 people on fire, stabbing with ice pick and ran out of crossfire.
When I tell you that shit like that, remember you,
All yours.
I was saying that shit next time.
But we should have used the strip mall.
Yes.
Yeah, just take the script on.
Take the
You
strip
need it.
mall, if you need it, you got it.
Well, I ain't never had a monster before. I'm like, I ain't never had it before. I don't
Any antibiotic increases the good flora and the bad flora.
know. Honey, just take the
And,
numbers.
and speaking of bacteria and antibiotics,
There we go.
there we go. So always make sure she gets fluconazole.
Always,
Hey,
always.
You call me and I'll call you in the script.
Always. Yes, that deal was.
And she probably needs, you know.
And I thought
So
my
there's
cough
stuff
and
in
my
the device at the same time.
And the flagyl
And the triple dose, the triple,
and some Zofran.
yeah, because it's nausea.
Yeah.
Really? You had 3 of them?
For what?
STDs all at once?
Oh, I had to use the patient. Oh, hell no! Can you imagine how these old ladies feel?
Hey, we had a 60-some-year-old female in the nursing home came in with trichomoniasis today.
Well, and I've also heard that the geriatrics, like there's a community down in Florida that STDs run rampant. And yes, sir.
What's the age down there?
Oh, no, these are like in the 60s and 70s.
Oh, too old for me. I was trying to think.
Right?
That's the one shit.
Oh, hey, I'll go ahead and write my prescription.
And there's an 8 to 85.
I mean, I don't want
I'll write these prescriptions and then we go together.
Right.
I can't write my own prescription.
Right.
Oh, man. I used to work in their office. Dude, I call that woman. I understand what they do with their bodies down there.
Tell me. The picture. All right. Well, quick review of antimicrobial therapy. This is going to be a quick overview. Factors for treatment, identification of the organism, the spectrum of antibiotics, the sensitivity of the organism to antibiotics. A lot of times we won't know that for a couple of days. Tissue penetration, metabolism and excretion of the drug, side effects, adverse reactions, and compliance. Penicillin. As your natural penicillin, penicillin G and penicillin D. Okay, penicillin resistance, ampicillin and toxicillin. Aminopenicillin and amoxicillins. Then you have sometimes that are combined with a beta lactase inhibitor, which would be innocent. And then you have your extended spectrum penicillin, which is penicillin taking the vaccine. And spectrum of coverage, natural penicillin is usually good for staph, strep, and airways. Not good against gram negative. Penicillinase resistant penicillin has good staph coverage. And a lot of times, we don't really care much about it. And then the extended spectrum, like your dosing, is good gram negative, gram positive, anaerobic and acidomonas coverage. And then your penicillin coverage covers gram negative. Clinical uses for penicillin: streptococcal pharyngitis, otitis media, cellulitis, pneumococcal pneumonia, dental abscesses, dental procedures, and STDs. And you see the picture. Penicillin cures gonorrhea. Now you know two things.
In 4 hours.
In 4
Not
hours.
for today.
You're done now.
We'll be back on the street more tonight.
Oh. Side effects: anaphylaxis, skin rash, GI intolerance, nausea, vomiting, diarrhea, which is one of the most common side effects of any medication. C-diff associated diarrhea, itching, and renal tubular inflammation. I'll walk through that now. The cephalosporins. Yeah, 1 through 5 generation. I think there's out with a 6th one now, but I'm not too familiar with it. So the first generation, cephalosporin, cephalaxin, Braswell. Second generation, cephalosporin, second. Third generation, there's 7, secondary on the stuff. And then, of course, your 4th or 5th generation are IV medications given in the hospital, cephalosporin, nitrogen, and cephalosporin. Spectrum of activity is better than penicillin for staph coverage. We also have additional gram negative coverage with some activity against anaerobes, and the gram positive coverage decreases with generation. So as the gram as you go down the list 1 through 5, the gram positive is strong at the top, and as you go down, each generation gets lower. But the gram negative coverage gets you have better coverage with gram negative as you get down the test lab.
So that's why most people get their 7% around themselves, because it's kind of good combination of both.
Yeah, good coverage, gram negative and gram positive. And the biggest thing is that we always consider about cephalosporin and penicillin, that cross-reactivity. It's like they say it's less than 10% cross-reactivity for someone who's allergic to penicillin and cephalosporin. I think actually the real number is like 6.7, something like that. So I have not seen a cross-reaction given cephalosporins with someone with a true allergic reaction to penicillin. Just because grandma said you're allergic to it, don't mean that you're allergic to it. But they still won't. They always put on their allergy list allergic to penicillin, they might not have a true reaction.
But when you're allergic, it just makes me nauseous.
Nauseous? Well, give you this some Zofran for the noxious feeling.
But they're paying 10 out of 10, I keep saying.
Wait, you forgot something. Yeah, what's the thing? It's a 10. When you do the shit in the stakes. Yes, positive text sign. It's a 10, a 10.
10. Yeah, we have that all the time too. And I, the bad thing, I document it in my chart all the time. Because, anytime I give any drug, whatever, I can see most of the patients sitting where the room is. If I go by and they're sleeping and snoring, I know they're feeling pretty good. I document patient, know keep the stress, patient sleeping, appears to be no discomfort. And but when the nurse they go to check the vital signs, wake them up, give blood pressure. Oh, I'm hurting. They did. We had one girl, nurse said, her name's Sheila. She's wonderful. She goes, "You're not hurting." Yeah, she's very nice after nursing, And she called my out. "You're not hurting. You just there sleeping. You don't have no pain. What's up with you?" I mean, that's how she is. She's wonderful.
I've seen it.
Yeah. We have a big security guard. And he was working one day and making he dropped to cry a little bit. Yeah, he had a kidney stone. But yeah, but that was a thing. I mean, he couldn't move. But he got morphine. So he got delighted in himself. We liked him. That treat him, that keep him happy so they protect him. Self-scoring spectrum is better than penicillin for staff. We just went over that. As additional gram-negative coverage, as you increase the generations, you have better gram-negative coverage, and then as you increase, you have more decreased coverage of gram-high. With some activities with anaerobes. Clinical uses: community-acquired pneumonia, cellulitis, biliary tract infections, cystitis, sexual transmitted infections, and surgical prophylaxis and non-stimulating infections. Some of the side effects are self-scoring. GI intolerance is the biggest thing. Elevated liver enzymes, bronchospasm, anaphylaxis, colitis, leukopenia, and hypersensitivity with penicillin allergy. We just discussed that possibly. Carbapenems, intrapenem, and imipenem. Clinical uses: vesicular infection, abdominal and pelvic infection, skin structure infection, pneumonia, bacteremia, and osteomyelitis. Glycopeptides, such as vancomycin, spectrum is gram-positive and has good nurse coverage. The resident coverage gram-negative. That's what you do with dosing. Clinical use is bacterial infections, pneumonia, anthrax, C. difficile infections, and hemocolitis. Side effects for bank, red man syndrome, which occurs with a rapid IV pulse. Hypertension can occur. Fever, nausea, vomiting, otoxicity, Stevens-Johnson syndrome, dizziness, vertigo, and nephrotoxicity.
So one time told me just when other toxicity, looking at the ears, it looks like a kidney. So if it other toxicity, it's got nephrotoxicity. You think about the shape of the ear, the shape of the kidney.
Oh, never heard that.
I've heard that before.
For vancomycin is very common for red band syndrome with a diffusion-related reaction consistent with vancomycin. It typically consists of pruritus, an erythematous rash that involves a face connecting upper pressure.
I've given one person that before.
Bad nerves.
No, I was early in my career.
Red man syndrome, it's like I said, it's a rate-dependent infusion reaction, not really a true allergic reaction. Clinically, it's flushing, erythema.
Oh, good, thank you.
Yeah. Brutus affecting
the upper body, neck, and face, more than so the lower body. Allergy and hypertension, and the management is to stop the infusion. Here's transport a patient with vein. They have a nose or Van syndrome. Pretty much stop the infusion, administer an antihistamine, and then once the symptoms have resolved, you have to restart the veins at a lower dose or lower, the slower rate. And of course, the Van syndrome is greatly activates mast cells with the histamine and it's often medicine. Antibiotic inhibiting protein synthesis, many glycoside, tetracycline, and macrolide. Glycoside, azithromycin, and thermomycin, suggestion for gram-negative coverage. Clinical uses of UTI, pyelonephritis, eye infection, gram-negative sepsis and pneumonia, intra-abdominal infections, and meningitis. And of course, some of the side effects. So on the good side is hepatotoxicity, ototoxicity, and toxicity. Most common symptoms for ototoxicity is like ringing in the ear, dizziness. You can actually have hearing loss. So meaning what the cartoons will show they have a lot of effect on the kidney. And tetracycline, they've been around a long time. And tetracycline, doxycycline, minocycline, and I have become more favorable with doxy. I kind of like doxy a lot more. It has good coverage for gram-negative, gram-positive, and most of the coverage in the end. So spectrum, strep, listeria, chlamydia, and and of course clinical use of STIs, urinary tract infections, Lyme disease, West spotted fever, acne, bronchitis, pneumonia, skin infections, and cellulitis infections, abscesses. GI tolerance is going to be common side effects of all antibiotics. Side effects for doxy or the tetracycline is tooth discoloration that's irreversible. So you do not give children any tetracycline or anything. Phototoxicity, vertigo, and fungal overgrowth. The children with contraindicated. And as we showed you a couple of pictures. Children with sick lung.
Dr. Kish is going to know anything more are going to be present. That next Monday, yeah. That next Monday, you might have to take a copy of this one. What is that? He's going to ride there in neonatal assessments. So, do you like having your y'all will be here?
I'll be here.
Who?
I'm on. Yep.
I'll be here at 3. Rob, Alan, maybe or not.
I am looking, it's 17th of Wednesday. And I am working the ER the 17th. in the 18th.
Ashley, will you be here on the 17th?
Mm,
Ashley, I didn't hear you.
I don't, probably not, because if I'm not mistaken, that's one of my days I had to swap for doctor's appointments.
Okay. All right. Taylor?
Yes, sir.
Yeah, can you be here on the 17th?
I'm supposed to work, but I might be able to find someone to cover for me.
Okay. I'll put you down as maybe. Leslie?
I am not sure. I'm looking right now. I'm on call that day, so I doubt it.
All right. Thanks, y'all.
Okay. Fentanyl is chiefly used as tetracycline. Children receiving long or short-term therapy with tetracycline may develop a ground discolored disease. The drug is probably due to property and the formation of working to any pregnant women and children under the age of 8.
My niece had it before.
Just get it for her.
Don't care about not spotting that thing.
What, when was that? How long ago that been?
She's adult children of her own now.
Many
I
years.
was married to my first wife, but married her for 30 years.
Oh. They might not have known it back then.
Right. Well, no, they did.
Oh, they did?
At the time, that was the medication choice for documented party. I think it ended up in bed. As a matter of fact, we were in Carteret County.
Oh, really?
My brother-in-law was installing a medical patient management system at Carteret Hospital. Or at some big hospital. We were staying at Motel there on the main drive.
All right, is there macrolides, agents, azithromycin, and clindamycin, spectrum, staph aureus, mycoplasma, and chlamydia. Medical uses, upper respiratory infections, pharyngitis, otitis media, pneumonia, COPD exacerbation, pneumococcal infection, and urethritis. Biggest thing you need to be concerned with the azithromycin is just prolonged QT interval. That's what I think off the top of the head. I had a patient who came to the ER about a month ago with a pneumonia, and with the Curve 65 score, she was only a 1 because of her age, so she really wanted to discharge her after she got her IV azithromycin. And sitting there watching her, she was happy to sleep and she wouldn't be tired. And of course, she converted on her own. But we had a pre-EKG showing before the azithromycin, and then after the azithromycin showed significant prolonged QT prolongation, we had to admit her to the hospital because of it. So I think of real life experience with I'm kind of
prolonged QT.
Before the azithromycin, no, it was a normal when we showed. And then we gave her that, and then she ended up having it into detail. They pretty much just took her upstairs and just wait till the azithromycin pretty much runs out in duration. You put on an antiarrhythmic just to switch to antibiotic. So that does happen. 48 DNA synthesized inhibitors.
Hormones and supplements. The appropriate antibiotics. Make sure your patients take them as directed and finish the whole prescription. Supplements, agents between bacteria, septa, and sulfamethoxazole, like method. And it covers mostly, covers most gram negatives, gram positives, some protozoa, and chlamydia infection. And clinical uses, we use a lot for UTIs, skin infections, gastroenteritis, meningitis. Of course, the side effects is pretty much all antibiotics. It's going to be GI intolerance, nausea, vomiting, RSV, cardiac, yeast infections, pancreatitis, and we see a lot of TB. And chlorine, agent ciprofloxacin, levofloxacin, and marcofloxacin. Has a very wide spectrum. There's staph, gram-positive, gram-negative, pseudomonas, and atypical. Has clinical use of severe urinary tract infections, gastroenteritis, respiratory infections, prostatitis, and skin infections. We don't give this out as much as we used to, especially the Cipro and the outpatients, like a lot of big black box warning on the medication now. So we're seeing not as we in our organization, we're not giving it out as much as what I'm sure still other people give it out, unless that's the only medication that we cover for sick kids or dogs. There's a lot of tendinopathy type problem, and these can be permanent problems too. There's a black box warning. I thought I wrote it down somewhere. So for rupture of the tendons. That's the black box warning for that. Tendon ruptures and everything. I thought I put a slide in there, but it must not. It comes up big black box warning. First thing I see. It causes tendonitis, tendon rupture, peripheral neuropathy, and CNS effects that may all occur together. Tendonitis and tendon ruptures may occur during treatment for months after treatment. And of course, the risk further increases in older patients greater than 60 years old. Over 60, increased risk. But like I said, we don't give it out as much unless it's something that we have a sensitivity for, or a bug or something that going to cover it. And that's the last resort when we might give it something like that. I mean, of course, you got to leave license, but any of those still have a black box. Prolonged side effects, all GI intolerance, headache, headache, tendonitis, liver function, elevated, delirium, dizziness, dyspnea. And of course, the adverse effects would be hypersensitivity reaction, anaphylaxis, severe depression, QT prolongation, dressage, tendon rupture, aortic aneurysm, nephro and hepatic toxicity, and peripheral neuropathy. So there's a lot of adverse side effects when you come back to clinic. And that's been a quick overview of that. I love it. Got one more slide, President. That's supposed to be Robin.
Well, this is 2020.
Well, I can delete it next time. TikTok, I watch TikTok all the time.
You're kidding.
What?
You can't operate a computer.
No,
You
I'm,
can do
hey,
TikTok.
the only reason I listen to TikTok and see what the new fad is, because ByteDance, which is the parent company that owns TikTok, are thinking about going public, and I'm gonna try to get into the IPO.
They're owned by the family.
I know that. But they're talking about
What's wrong
going,
with Chinese people? Are you ready?
they're thinking about going public, with an IPO, because I can get in on the ground floor of something cheap, I might make some money off of
But people thought the same thing on Snapchat too.
it. Yeah, but it's only money.
You only say that if you have to.
Right.
I mean, I could throw, several $1,000s and not worry about it.
Especially in that case, I mean, you're more welcome to take it. Make it rain.
All right, let me get out.
You're gonna fish one.
Yeah, I'll make a couple now.
Andy Cup.
It goes to your call.
Because I need it.
Yeah. Actually, we just bought me a brand new all black 400 TRD front. I'm good to go.
Nah. I did. Well, this is the least amount of slides of the whole thing.
But it's the worst.
It's gonna be quick and easy. I like it quick and easy. Get it done. Lynn said I had to do drug calculations. Right. But everyone here should know how to do it. If not, we should have an app that can do it too. For access to it. That's good. That's what I do. I got a couple apps that I use. Someone told me in the past that it's why to memorize something you can access it quickly.
You have to memorize it to pass the test.
To pass the test. Once you pass the test.
It's free game.
All right. This is going to be short or long, depending on how y'all interact. Well, answer the questions.
Short, let's go.
Calculating drug rates. That's the land in the corner. Mhm.
No joke, it does look like Dr. Pine.
I don't know who he is.
Coolest old man.
Bolus Drug Administration. There's a formula to figure out the drug administration. Like a volume to be administered, equals the volume on hand times the desired dose, divided by the dose in hand. Pretty easy. Your order to administer 4 milligrams of morphine IV on hand, you have a 10 milligrams of the drug and 2 cc. And of course, for the formula on top there, take the volume on hand is 2 milliliters, 2 cc, times the amount of your desired dose, which is 4 milligrams of morphine, and you have a 10 milligram vial. And then you take over 2 milliliters times 4 milligrams, which equals 8 milliliters over milligrams. and then divided by 10 milligrams. And the milligrams cancel out each other. And we divide, we have 0.8. Simple. Right?
Yep.
Any questions? I mean, it's simple as you do it. So, Carrie, if you have, yeah, you can use calculators, it doesn't matter.
All right. Let's see what I
Make it easy, I want to think of it. I don't know how much is the salt measure? The 2 ml? You are ordered to administer 80 milligrams of sodium medrol. IVP push. On hand, you have a 125 milligrams and 2 ml. You know, probably up to him. I don't know how to think of that.
Wait a minute, and I'm forgetting all the
You were told to give 80 milligrams. Here, look at,
Okay.
I can use this
All right.
board over here.
Well, can y'all let,
Bradley Dane, you have this thing on your computer as a whiteboard. You just-
That's too complicated, man. You're ordered to give 80 milligrams of sodium medrol. And it comes in 125 milligram 2 ml vial. So, with that, the volume on hand is 2 ml. You can stop volume on hand is 2 ml. And you want the desired dose of 80 milligrams. And divide the dose on hand. And we have 125 milligrams on hand. And that will equal to 160 milliliters of NP over 125. And the milligrams will cancel out, and I need to calculate to figure that out. 1.7. 1.28. So you get 1.28. Easy. Right? What calculator? Or the, any questions? You guys got it? Now it gets to the harder part. We're building up the big one. IV administration, you have a micro and a macro drip set. The micro set 6 drops per ml with 1 cc. And then you have a mac and you do a 10 or a 15 drop set, depending on what agency you have. What do y'all have? 10, 15? 15, 16.
but we have another one that
60.
we use.
It should be a 60 for your drug dose or for your infusion. For your lidocaine or your vitamine or dopamine. All right. Fluid volume over time. Volume times the drip factor over the time in minutes equals the drops per minute. So if someone gave you an order to infuse 500 milliliters of normal saline over 60 minutes and you have a drop set of 10, then you would be giving them 83.3 drops per minute. Y'all carry pump, IV pump? So you have to calculate close to it.
Do 500 divided by 6.
Yeah.
500 divided by 6.
I usually just take the zero off,
I did too.
count the zeros, cancel those zeros out. So you, I thought I was like, we 50.
Just take the 0 off the 1 and the 0 off the 6. And then so it's 500 over 6.
Over 6, yeah.
And then 83
But
points.
I still have to, I just to divide it out. But yeah, I do a lot of cancellation. But in the emergency department, I don't have to worry about it because I just tell the nurses I want this much. And they supposed to take care of it. But I did write a write up to the owner a couple of months back because I wanted I ordered a normal saline at 100 an hour. And she had told us that they could 30 minutes. And the problem was, the patient had severe department syndrome. And I was flying him out to Greenville to have a fasciitis thing. And she wrote, she told the whole thing. So now it's pressure. I wrote her up. Matter of fact, she got fired for that. But I wasn't her only, I guess they've been adding
The straw that broke the camel's back.
yeah. But yeah. And then I had I guess about 2 people back. They're both nurses.
That was a long ride.
Why? That's something I'm asking.
But the thing about it is, if you have a specific order, that's what you should do.
It's not your fault, nurse.
No, I got really good nurses. Right. So,
And the more you fire, the better your group is.
yeah, you
Get rid of the bad ones.
get rid of the bad apples. Yeah. Yeah. All right. So we all got that. You know, real quick. Yeah, he said go on. He said do another one. That's what
I'm awake right now, so I can do it in my sleep. Maybe I need to be awake.
Yeah. Let's see. Trying to think of easy. For easy people. That'd be too easy. We're gonna do a 30 big 30 milliliters per kg IV bolus. And the patient weighs, I'm making this up as I go. 75 kilograms.
Okay. Is this a Hartman formula?
No, I'm just,
Don't give him ideas.
now if you want to do a 30 ml per kg bolus, and the patient weighs 75 kilograms.
Wait, hold on.
Over how long a period of time?
45 minutes. That sounds like a good.
Are you using 10 drop there?
Whatever you got on your truck. We're using a 10 drop set.
How many minutes?
Did I say no? Oh, I said 45 minutes.
Damn it, Queen.
So
Now I'm just wondering.
we're gonna do a 30 ml bolus per kg. The patient weighs, what did I say, 75 kilograms? 35 kilograms. And that is how much we're not changing that to pounds.
Are you actually writing something on the board?
Yeah. Right.
I can see it this time.
I'm going for me, so I want to get the numbers. And you're instructed to use it over 45 minutes. So first thing we need to do is get the dose has been ordered, the volume. So you want to take 30 ml per kg, it's 75 kilograms, so 30 times 75 is a lot.
2,250.
2,250.
No, 2250.
2520.
2250.
Put a two in front of that two,
50.
and then put a zero behind five.
There you go.
That's the volume you want. That's the volume you want to administer. Your drip pattern was a 10 drop set. And you're going to go over 45 minutes. I've used my calculator now. So the biggest thing is just setting up the formula and then 9:30, man. 9:30. Corey just texted me.
Okay.
He'll be here at 9:30.
You ain't waiting on me.
I'm not waiting on him yet.
Well, you probably leaving wrong.
No. I'm going to Axborough.
Oh.
So Axborough. No, Axborough. You want
Randolph
Axborough?
County.
You're going
Yeah, I'm going to
to.
Axborough. And what did you get? That's the answer. Can't count those drops out
So you just roll it down like.
So that's 8.3 drops a second.
Yeah. Water.
there. You use the IV pump. But the biggest thing is just knowing how to plug in the formula. Plug in the numbers. Once you got the numbers, you come up with your rate. You know, Carrie?
This is so much easier than hearing it. I forgot to call on my calculator. Not to say out loud.
No.
So, you,
Give her a name.
you,
It should be the
I'll do that.
calculating milligrams a minute. Take your dose times the drop factor. And your solution concentration, it is the drop per minute. And I'm not sure what drug they're using. 2 milligrams can be given with a 60 drop set. And we have a 4 milligram solution concentration. And then once you put the numbers in, I cancel like you do. 2, 4, 2, and 30.
That's
30.
yeah, 6 drops in is what it is. 1 per hour.
Okay. Basic math. You know your formula.
So 100 an hour with a 6 drops in. So the 60 and the 60, they both cancel out. So it's just 100. You understand that? Okay.
She's a paramedic.
I got this. This is my phone.
She got the pen.
So let's do a part formula.
Oh. No, I don't have it in there. I haven't seen it. I'll add it next time. I never thought about that. I'll do a partner from the. It'll be easy to add. Calculating micrograms per kilogram per minute. Got your dose times your kilograms or your weight times 60 minutes for your solution concentration equals your cc per hour. So this is where you come into like your antiarrhythmics.
Oh, good.
Impressive.
Hold on.
So if you were given the order for 5 micrograms a minute for what, 75 kilogram patient, and you're using a 60 drop set, And your concentration of the drug,
I don't believe your math is right on that.
really? Hold on.
Should be 14 point something. 14 years.
Let me get my calculator out. Yeah, it's 14. See? You always double check it. Measure twice, cut once. Calculate twice and administer once. Because once you administer, you can't take it back. Or if you're old school, and you do it the cheat way, you just do a top method for lidocaine. Lidocaine is prepared by mixing 2 grams of lidocaine with 500 milliliters of B5W or 1 gram LCTP. We give you 20 milligrams with a 500 ml bag, we give you 4 milligrams per liter, and then you use the 60 drop set, 1 milliliter equals 4 milligrams. You're coming up right? Yep. Yeah, I'm here doing this. Everybody has it. And of course, we get the lidocaine clock, pretty much basically the clock. 60 minutes, 15, 30, and 45. And then you start with 1 milligram, 2 milligrams at 30, 3 milligrams at the 45-minute mark, and 4 milligrams at the 60-minute mark. Make sense here? Right. So you are preparing to start a lidocaine infusion on your patient. You would like to give the patient 2 milligrams, this is for her, 2 milligrams per minute. Using the clock method, how many cc's an hour did you set your rate at?
Sorry.
Hello?
You got a dial close to microchip. You got everything done.
Yeah, we didn't have one. So, like you said, it's going to be 30. Yay. Very simple, quick, easy, to the point. Right?
Easier to figure out by sense.
Oh.
With the population.
Who's been watching? Brad Ginsburg?
We did have some base bounce.
Battery.
I didn't know who's coming. He's not on the instructor list.
Randy didn't want to do antibodies now.
Rather do it. So, okay. And of course, you have a dopamine clock. Got a lidocaine clock and a dopamine clock. Dopamine is prepared by mixing 800 milligrams of dopamine with 500 5W or 400 milligrams of dopamine in 250 ml. Which gives you a concentration of 1.6 milligrams per liter. So you use a 60 drop set, which you should be using for dopamine, 1 ml is 16 micrograms. And your dopamine clock. 400, 800, 1200, and 16. So you're about to start a dopamine drip on your patient. You would like to start the drip at 5 micrograms per kilogram. Your patient weighs 100 kilograms. Using the clock method, how many drops per hour would you start using the drip?
start your trip on. You order 5 micrograms per kilogram per minute, and you take it as 100 kilograms. Anybody?
18.75.
That's just what I did. Okay, got it done? That's the same that I just gave you, the information. So you're using calculator, you're using calculator. Yeah, I know, but you're using a calculator. You're supposed to use a clock. It's a rough estimate.
I mean, what I do is your dose divided by the 1600
Mhm.
and you 0.6 something, then multiply that by 60 to give you how many drops.
Right? And using either the lidocaine method or the dopamine clock method, that's just a rough estimate, and then you're going to titrate your response. So it should be right around 17 cc's an hour. So use estimating about what. That's when you start your response. Using the clock method.
I like the
Yeah, what?
Diddy.
Dopamine diddle?
Diddy.
Weighted pounds, drop less than subtract 2, you need 5 miles. 16.
And ours is always pretty big.
All right, say it again, Ben. Take weight in pounds, weighted pounds, drop the last number, subtract 2, and subtract it. Make you 5 miles.
And it put me at 20
That's
cents an
easy,
hour doing
yeah.
that.
It has to be 1600 concentration. Yeah,
I always remember that.
yeah. So if you need 3, you gotta titrate it down. I'm doing this for 2 months. So I use it double. Yeah. What'd you get from? Some severe. We got their septic. We could. She probably had some breathing problems too. Cats. We didn't know at the time. But she met all the criteria like unassigned process and all that. We think that's what was really going on. She's got a multitude of very good. You think so? What was the person we got? The highest we got, finally broke it up to 20 miles. You do any pills or anything? So she got a run the fever? She knows the vomiting. That's what the days. 2 days before that, she was craving something foods. Not reason for highest we got in 78 after the 2 months later.
So I think the math is rough. It's a rough.
Yeah, that's just a rough estimate. He did about.
So 500 mics is what 5 at 100 divided by 1600, which is your concentration, equals 3.25 times your grip factor, 75 for 19. So 19 is
I
close.
just see the person roll out,
Yep.
you know, the other A, B, C, I mean, roll those out. 4, 12, oh, right.
Making a note to add parking. Looks bad, so unless you did, so you do, so you have the number, 10 miles.
Yeah, you
You
never
don't have
get.
them step up on the scales in the truck.
No, no, our stretcher, our stretcher has to wait, you know. Like your hospital. Right.
Yeah.
See, I don't see nothing wrong.
Actually, not so much.
We got embroidered seats.
No, we only have, we did, that truck's in the boneyard now.
Was that the brandy truck there?
That was the branding truck. Head on, yeah.
I thought, I think.
I have carried with my thing.
Been there, done that.
And that's a nice website. I don't know how to share it with y'all, but it's a very good website. So when God just started in touch and put it there.
How do you share it?
You that copy it, no, you let them take it.
You copy it and email it to me. I put it on there.
Please,
I don't know what Moodle is. It's something about Moodle.
I know you're all about this noodle, but last time I had it on, there was so many ads, I was up there.
That, your friend's
Okay, all
project, not mine.
right, we'll have to fix that. Yeah, like I got
It's
so
a free-
aggravated.
it's a free site club, but have that.
Well, that's all I have today.
It's been fun.
This is all pretty much a refresher course. You learn as you go. Anytime you have drugs on the truck, you should be able to know your indications, side effects, drug interaction with each medication, anything that's on the truck. And of course, when you go to the hospital, you might be picking up a patient. You might have a drip rate or something that you might not be familiar with, but you should be able to have a drug resource that you can go to. Yeah, to be quick.
Y'all, please thank y'all for your time.
Thank you.
Bye, I'm leaving. I came up a day early.
I told them,
I almost came a whole day early.
I did. I know. I was an hour in the route when I realized I was on the wrong day. So I got a ride out with something I went to turn around.
Just make a full vacation out of it.
How do you take a vacation still?
you can go hiking at Kings Mountain.
Be honest. So I can.
I'm dead body.
You used to be a hiker, didn't you?
I did. I broke my leg. Did that in St. Louis. Hiking the trails. Of you know, here when I told you about my accident on the truck with electricity, so I have a foot route. I have no feeling in my left foot, left lower leg. Climb up the rock, trip, truck. I got a rod in the leg. Did that in a PA state.
So how do you walk when you can't feel your legs?
What?
How do you feel legs?
Off the ambulance.
Like the ambulance?
The ambulance.
You have plugged before on.
Scary.
We run a 24-hour shift at the time, and it was 10:30 at night, so I'll never forget the times and everything. And then was back in the day, we just finished all our basic. My partner was outside the day, smoked a cigarette. I was inside, I stripped down in the store, no shoes, no socks, no nothing. We converted the whole house into a place. So I come to the kitchen, going out to the garage, open the door to go step down. So I stepped down on the step, brick step, stepped down, and my last step was this foot here, and the ambulance is right there. So I come down, step over and grab that corner, what do you call it? The shoreline? No, I'm at the very back of the truck. The aluminum plate that the diamond plate. Set that and grab the corner of the diamond plate when the current went through. Yeah, a part of it should not be 36 and control the whole thing. End up being the gentleman who is the name for the agency wired the shoreline backwards. So when you plug shoreline into the truck, the whole truck chassis is locked. You would never knew it as long as you were wearing your boots and everything, but this lady from the ground. But I walked out there with blue shoes. Had 3 surgeries. She walked there.
So I'm gonna say.
Yeah, why did that happen to me?
I had no feeling.
It almost killed me.
You look like you.
I know, he's loud.
I didn't watch, you was west side. I put it aside. But you
Oh,
know,
he
Cleveland
keeps on
County
feet.
Park.
It's not.
Yeah.
I'm like, when I show my foot and I'm like,
I can't pull out at all. I can look what he told you, all that's done, all through here, all over. And what kind of, walk to work day?
So at will, say that. At will. Right to work is in work, but at will is they can fire you for no reason.
Well, you can't say you're employee for. Then I close it, you have to be paid more. Something the right back, you have a reason, I don't think it is full. Walk right and shut. See it, that's it. There's a lot of the front and back, so you know, which.
Damn near killed me. You would have.
Yeah, if I had this on something, then you turn it this way, it's all probably with me now. So this time, this one,
That sucks.
how can you do that?
I mean, I didn't know, but I didn't know I could be here.
I've never seen that. So, yeah. Let's go to work.
Oh, don't put them on the table unless they're off the floor. Alan, you can drag it out of the kid. Get it up, come back. You know where it's done.
I think it's somewhere back there.
Back corner.
Hey, you go in.
Guys, I'll get, those that are online, send me the, YouTube, they're available on our website, YouTube and all right, guys, we have.
Do what?
Does anybody have anything to be thrown away before I go out on the race?
Are you coming back? Or anything else?
I don't think they're
Hey, all the time. I haven't seen you since AMLS.
I'm going to call for the PTO. That's what I'm saying. It's just scary how close I was to helping to me, but they weren't.
Carolina.
There was one.
You know,
Steve, I get mine.
that was the move. It did better for like 4 days, but it gave me an opportunity to finish my undergraduate and then I decided to go to PhD. So you know, every I have pain in that foot, kind of weird. Like the pain is like stabbing pain in the foot. I have to take it on my foot. Like a lot of times I have to either take vinegar or narcotics. I will first. Only first month I get the narcotics. But what makes it feel better is let's see here. Now if you take my foot and you just do this, I'll come off the wall.
What?
It's a very high sensitive. So if you take my foot and you do this and you do that really hard, that's the best thing ever. I will lay there all night long and I could fall asleep with that. So just like that, it hurts some pain. It makes sense because it could be like a super severe sunburn. It damages his nerve endings, like super sensitive. That's what makes it itchy so bad. That's what it is. I have a peroneal nerve. And then it was fun that came out, and everybody kept snoring. That's what it was. That's what I'm saying. When I flipped it up, and the lightning bolt shot up to the see what if I had had mushroom bread, I would think, I mean, let's say, hey, this is quick.
I wondered why not smell. It smelled like it was burning, like something was burning. I didn't know. I didn't think you.
You know what the smell was? It was the insulation in the ceiling still on fire. Maybe it's here with the tips. Oh, we did. We switched over. Oh, good. I don't know. Well, I got almost out of the that way you can work in. I'm gonna use the bathroom before I get on the road. Grab the tea before I get on the road. I'll go buy another gallon. Early, yeah. But yeah, if you not hang out for 40 gonna make it for 9:30, that's what I'm. But Gary, if you get some nice town for dinner. You're what? So you can't eat first. Okay.
Feel all day long. Susan's from the bed.
I'm going to take three that I'm. Go slow. Take your breath off. Just take it, you know that. All right, so we have a test. Are you intended this for UNBC client or are you protecting the test? I understand that part, but I like coming out. Steve Gray, the guy sitting from me, when the UNBC met for 15 years, and he said, I'm gonna sit through 48 hours to get UNBC client. I might as well sit through another. So not the final test. Punch it again. Whatever instructions I'm looking for taking today's test. Taking all moving at home. Get to work. You won't know what you remember though.
I saw that.
But this will be more specific. Chapters that are being covered if you live here forward. But anyway, everybody on move, no time. Only one. You need to think. Right.
So that just got me a worse one, right?
No, this is. Yeah. Bye, Terry. Bye, Jeffrey. Oh. Okay. I don't remember, but I hope they're on. Only one person can take it now. Wow. Don't forget your, I just saw it. I'll do that. Okay. I mean, I'll leave the projector here all the time. I mean, you can hear more anyway, right? Why is this online? Let's watch. $1,000 iPad when it's $100. Well, they won't understand how to use that. Right? Yeah, they have no use for projectors, they have use for an iPad. How many PAs work with you? I have a couple that, I mean, we'll give you a couple, but I don't want to, I also have, stroke loss support. I thought that was a pretty good. But I'm on, I know for you, but I'm already got,